Yeah, exactly.
I agree.
Most of the talks are it's more making a case in science.
Hi everyone, welcome back. So to try and keep to time, I think we're going to kick off promptly. So we've got an exciting set of talks this afternoon, and our first talk's from Professor Emma Robinson from the University of Bristol, talking about negative affective biases following ketamine. Thanks.
Can you all hear me okay? Brilliant, thank you very much. Well, thank you very much, firstly, for the invitation to come and speak and present some of our data. And particularly, thank you, Rupert, for the title, because this is not mine, and I think it's actually, it's a perfect title for what we're going to be, what I'm hoping I'm going to be talking about. So just to highlight, so the main conflict that is relevant is that some of this work has been funded by a joint collaborative grant I held with Boehringer Ingelheim, and also more recently working with Compass Pathways. So I just thought I'd start very briefly by talking about my thoughts. So these are just my kind of thoughts on why we've made so little progress in understanding and treating major depressive disorder. And so, because I mean, I think it is really important that we recognize that it's we have really limited knowledge about the cause of major depressive disorder. And when you're an animal model person like me, and I'm going to talk all about our work with rats, it is really hard because we're told that we have to align our data to, predictive construct and face validity. But as we don't have that, how can we do that? And we've heard already about some of the challenges with animal models and translating that. And so I think, it is a really challenging disorder to study. I also think we're always playing catch up, and I'm really excited about the rapamycin data because it's given me another thing to start exploring in my animal studies. Because, as you say, serendipity number 3, we seem to always be utilizing the pharmacology to then try to gain insights. And I'm not sure necessarily whether that's the right way, but it's certainly dominated the way we do our preclinical studies. And we are generally playing catch up. We get variation clinical benefits. For my PhD started in the world of delayed onset of action and the idea that we were going to use antisense oligonucleotides infused into people's brains and we were going to reverse this rapidly. It was great fun, but it didn't work. And it certainly, but it taught me an awful lot about, some of the challenges around animal research. And then, of course, ketamine came along and everyone thought there was a delayed onset, and then ketamine's thrown into the picture and there isn't a delayed onset because suddenly you can use this pharmacological agent and you can change mood really, really rapidly. So it prevents lots of new opportunities for us. But as an animal researcher, there are real limitations, I think, with the current readouts that we use with animal models of depression. And I think they've been really helpful, but I think we do have to recognize, and I hope that what you'll see is what we've tried to do is to start at the beginning and try to look at a new readout for depression-related behavior in animals so that we can then ask questions about the mechanisms rather than working with models which we know have limitations. And so the lot of work is focused on stress-related deficits, so inducing stress in animals and then seeing, and that may relate to depression because obviously stress is a factor, but it may not. And the stressors we use in our animal models, I think we do have to be careful about assuming those are the same types of stressors that you see with in clinic. Conventional readouts don't recapitulate the human condition, so the forced swim test, even the sucrose preference test, I think it's difficult to say whether that really is the same as anhedonia. And there's also many examples of false positives and negatives. We have to be really aware of that and poor translation from ideas. So lots of stuff work really well in animal models and then don't work in the clinic. And it has certainly created a withdrawal of confidence from the pharma industry. Okay, so this is what we've done is we've taken this idea of affective biases in depression and I've suggested that it's a translational cognitive biomarker and it really builds from work that people who have looked at objective rather than subjective measures. So I can't do subjective in rats. They don't speak and they don't have that subjective. So I need to work from clinical findings that are objective. And so we know that emotional states bias all sorts of different aspects of cognition. And in theory, we should be able to look at that in animals. Major depression is associated with these negative biases. And of course, the work showing that these conventional antidepressants could induce these acute shifts, and that was not subjective. Patients weren't subjectively aware of it, but then it interacts with these environmental and social factors. So this idea that the brain, maybe these drugs are setting up a biological, a biochemical environment that facilitates then more positive social interactions, environmental interactions, and it's that combination that causes the clinical benefit. So we have two tasks that we've developed based on this. One is very much our own, the affective bias test, and the other is the judgment bias task, which is based around decision-making biases. And that was published by another group in the welfare field, but we've kind of made use of it. I will start off by talking about what we've done with the judgment bias task before I go on to the talking about the affective bias test. And so this task is based on the idea that affective state will bias your decision making, and that if we balance our study design and counterbalance everything else, we should then be able to make an inference about the affective state of the animal based on its behavior in this readout. And so the way we use this, and this is our version of the task, there's a number of different ones. And if anyone wants to know more, there's lots of data we have, and I'm sort of really cherry picking it for the purposes of this talk. So what we've done here is we start off by taking an animal and we train it that there are two different outcomes that it can obtain. So we take neutral cues and we pair them with a positively valenced outcome that is either very positive, so a high value reward, or less positive, a low value reward. And once the animals learn to discriminate accurately, then what we can do is we can probe their biases in decision making. So are they optimist or pessimist, glass half empty, glass half full, by using an ambiguous cue. So we present this ambiguous cue for which they can't. There's no prior information on which they can base. They have to think. We interpret the data as that it's based on the animal's expectations. So if they're expecting a more positive event, they will press for large reward. And if they're expecting a more negative event, they'll press for small reward. And we can do this we use random reinforcement so that they can't learn anything new. We've done quite a bit of work on this assay, and the findings are pretty good, but not quite what we had anticipated. So the first thing to say is that depression-like models are really good in this. They are much more pessimistic. So if you play them, the cues, their tone, they're much more likely to anticipate the small reward. And we don't change the reference cue. So the important thing is reference behavior stays the same. They're not suddenly just not responding. It's a very specific effect. But we didn't see what we expected. So based on Catherine Harmer's work, we were expecting the acute antidepressant to do something. Well, it didn't. But what we did see is effects with the chronic antidepressants. So chronic antidepressants made them more optimistic. But what is interesting and very relevant to here is that rapid-acting antidepressants induce this rapid effect and make them more optimistic. So there's a whole set of data. Most of this is published. Some of these data are not published, but what I'm showing you here. So essentially, these are acute or chronic drug treatments as labeled by under the line. If they go below the line, the animal is more pessimistic. If they go above the line, they're more optimistic. And all the data you're seeing here is at doses that are specific. So these are doses that are not making them emit more trials, take longer to do it, or have altered their performance on reference cues. These animals, this is very specific to these ambiguous cues. And we nicely get effects with anxiety, so making them more anxious acutely, that works nicely. The acute antidepressants, if anything, possibly because they make them more anxious, come out more pessimistic. But if you give them a chronic treatment with fluoxetine at quite a low dose, they become more optimistic gradually over time. And I've got the time course of this is published. But what was exciting for us is that the rapid-acting antidepressant ketamine immediately made them more optimistic. And it's quite selective. It wasn't doing anything else. And I'll also draw attention to the dose. So we get a nice effect with 1 mg per kg. So quite a low dose and not dissimilar to what's used clinically. We also see various negative, more pessimistic behaviors here with acute and chronic corticosterone, which of course is stress hormone. Acute restraint stress didn't do anything, but once they're released from the box, once they're released from restraint, they go straight into the box, and perhaps they can recover quite quickly. But chronic restraint stress does cause a negative state. And interestingly, chronic inflammation. So why I've put the chronic data up here is because actually what we don't get with things like full swim test or anhedonia in the sucrose preference test is consistency across risk factors, but we do here. So what we're seeing is we get more pessimistic behavior in these rats, irrespective of which risk factor we test. So be it inflammation, be it chronic stress, be it psychosocial stress, they all generate this more pessimistic behavior. But as this is, of course, all about rapid-acting antidepressants, I thought I'd show you these data, which I think are really nice. So we get a small but significant, more optimistic behavior with ketamine. We also see a very similar thing with scopolamine, which is the muscarinic antagonist, which similarly has been shown to have rapid-acting antidepressant effects. We've talked a lot, and we've heard a lot about the molecular mechanisms and the molecular effects of these different NMDA antagonists. And what we find here is a nice behavioral dissociation. So what we find is that memantine or MK801 have no ability to do this. So there is definitely something different about ketamine in this readout relative to these non-efficacious NMDA receptor antagonists. Now, we haven't done the molecular work. That's next. But it gives you some idea that we can behaviorally dissociate this. And I'll show you some data in our other assay, which I think are even more exciting. We've also done some work, sort of it's a progressive thing, but we've localized this to the medial prefrontal cortex. So we get some really nice replication of the effect. So we do infusions. Sorry, my spot is definitely in the wrong place. It should be up on the border of the prelimbic, infralimbic. Sorry, I must have moved it without moving the spots. So the infusion is actually should be on the border of prelimbic, infralimbic. And when we do the infusions, we replicate the systemic effect. So it does suggest prefrontal cortex is really important for what we're seeing. And this hopefully for you highlights this, what I'm saying about specificity. So what we've got here is ketamine. This is the NR2B selective compound, also having a nice specific effect on decision-making, or making them more optimistic, and scopolamine. Now, this is muscimol. So this is what happens if you just inactivate everything in the prefrontal cortex. So if you just sort of do a temporary lesion. Now, why I really think this is quite exciting is because this is disrupting them. So if we shut this down, you can see when you look at all the other measures, so this black bar is the one you want to look at. This is muscimol. So this shows you that they just can't remember how to do the task properly. So although they look like they're much more optimistic, actually by using these other measures, we can see that actually they've just generally been pressing things a lot more. So they make just more positive responses across the board. They've lost their accuracy. They're emitting more trials. So sometimes they just forget who they are and what they're meant to do. And then they're also making lots of prematures. So the advantage of this type of readout is that we do get these other measures that enable us to differentiate between what we think is actually a rather interesting, possibly quite selective effect of ketamine and these other drugs versus just switching off the prefrontal cortex. So we don't think that this is just down to this, it's not just a gross change in activity in this brain region. There's actually something quite special going on. Okay, so this is our affective state-induced biases in learning and memory. This is the task that we developed in the lab. It's based on, spent a bit of time chatting to patients, and I found it very interesting that patients with depression attribute less value to positive experiences. And I've always been intrigued by this reward stuff. I know we talk a lot about negative biases and negative, but I always think a lot of what's going on is loss of reward. And that's quite, to me, that seems to be very prevalent. And so I was really interested in modeling that. So we took the idea that affective state at the time a positive experience is encountered could bias the memory and subsequent recall of that experience. And we could model that in animals really quite easily, creating this assay, which we call the affective bias test. We take cue reward associations and we look at how affective state changes those can generate biases. So essentially in the main assay that I'm going to show you data for, what we have is a 4-day learning protocol where they learn on one day substrate A has food in it, on the next day they learn substrate B has food in it. Before, the food value is kept constant, so it's one pellet, one reward pellet, but we manipulate the affective state before one of those pairings. Everything is counterbalanced so that the only thing that can be driving what we subsequently see in a preference test is what we did to them, so the affective state manipulation. And the preference test is run over 30 trials, and it's the first time they meet A and B. So essentially, they meet the cues again. The cues should reactivate the memory of that substrate reward association, and they should use that then to influence their choice. Now, what should happen is this should come out as 50-50, because the value of the reward is identical, and it should be 50-50. But what we predict is that if we manipulate their affective state in a positive direction, then this will come out as a positive bias towards the treatment-paired substrate. And if we manipulate them in a negative direction, then this will come out as a negative bias. So I am not going to show you all the learning data because of time, but it's all published and there's lots of it. And if anyone's interested, I can show you lots more. And essentially, it all comes out how you would expect. But what we found was that ketamine didn't affect learning at all. And that was quite interesting at one level, but it also meant that we needed to think again about how we would test it. And so that's where we came up with this second assay, which is to look at the effects on retrieval. And I think this, I mean, it was one of those things where you just do an experiment because you think, well, we ought to try it. And then the result comes out, and then you find that everything after that is based on it. So it was actually a really exciting finding. And so what we do now is we use this assay to generate a negative affective bias. So we create a negative bias, a negatively biased memory within subjects. So this isn't something changing in the whole animal. This is just this one thing. And then we can test the effects of our drugs on retrieval. We can either do it acutely at 1 hour, or we can do it looking at the sustained effects. I'm not sure if the video is going to play. Oh, there we go. It's really simple. It's also really time consuming. And my poor lab spend hours training rats. So this is a quick summary of what we've got in terms of our published work. So what we find is that venlafaxine, conventional antidepressants, positively bias new learning, and that's consistent across all conventional antidepressants, but we don't see it with ketamine. And then what we get is that links in nicely to the amygdala. So if we lesion the amygdala, we lose some of these learning effects. In contrast to that, what we find with our studies with retrieval is that the biases are linked to, so we have a negative bias generated, and this is what the vehicle looks like at retrieval. So we see this nice negative bias, but we can attenuate that using ketamine, DOI, 5-HT2A agonists, and also the mucimol. So conventional antidepressants here have no effect. So we have data showing that if we give the conventional antidepressants, they have no effect, although I'm going to show you a very recent piece of data, which I'm quite excited about. And then also the ketamine does. Now, one of the problems with doing bias assays, so I should go back. One of the problems with doing bias assays like this is what could be happening with ketamine is, as you will know, they could have just forgotten who they are, or what they're meant to be doing. And that was, of course, a bit of a concern for us. And so what we wanted to do was look at the control and how sensitive this was and how selective this was. So what you're seeing here is an assay that is almost identical. The difference is that here we generate the bias using reward, not affective state. So these are affective state-induced biases, and these are reward-induced biases. So the assay itself looks almost identical. It's just that for these bars to occur, this is where they've learned that 2 pellets can be found on one day, and one substrate predicts 2 pellets. And that induces this really nice reward-induced bias. And importantly, what we get then is selectivity. So we can see that both ketamine, scopolamine, and deep brain stimulation of medial prefrontal cortex, they all do the same thing. They selectively modulate affective state-induced biases with no effect on a reward-induced bias. And we think this selectivity is really cool and really exciting. And I think that there is an affective bias circuit, and I think it's that affective bias circuit that's very sensitive to the effects of ketamine. And what is also really exciting is these data, and this is where it even more fits with the title that I was given about switching the bias. So what we're seeing here is that we do exactly the same, but we look at the animals 24 hours after treatment. So we pre-treat them. We literally just do the same pairing sessions, give them the drug in their home cage, and then test them 24 hours later. Now, I was excited because I thought I might just get a sustained effect. I might just see it sit here. But what actually happens is we invert the bias. So something is happening whereby the animals, I think, are reconsolidating memories after that ketamine treatment. And they're particularly reconsolidating affective memories because those affective memories are going to be stronger. So it's the same animal. So he has a control memory, has affective memory, but he reconsolidates the affective memory, we think, more. And what's cool is we can replicate it with medial prefrontal infusions. And also we've gone on to do the obvious, which is which of this is this protein synthesis dependent? I do want to do lots of molecular work. I'm quite fun. It's coming if we can get some funding. But this is just the first phase of it. So again, we've used infusions, but this time we've used anistomycin. So we've used a protein synthesis inhibitor. The acute phase, the anistomycin does nothing. So this acute phase is not protein synthesis dependent in our hands. However, what we find with the reconsolidation part, and why we think it's reconsolidation, is because this phase is blocked. So we get a sustained effect, as in after 24 hours, there's still this neutral, but we've lost this inversion. So we think that the protein synthesis is necessary for the, we think it's essential for that reconsolidation. And then just because we've only just got the data, and just because I was quite intrigued by it, we ran fluoxetine through. We hadn't run fluoxetine. So I was a bit upset when I saw this because I thought, well, it's not meant to look like ketamine. And then I was like, okay, well, it doesn't have a 24-hour inversion, but it's a bit dirty. But then we ran the control, and it's the most potent effect we've ever seen in our control. And we think it's emotional blunting. And so we think it's quite cool. And I'm very happy to explore that more if anyone's interested. I've literally only just got the data off. But what I want to do, because I'm going to run out of time, I've run out of time. So affective biases associated with decision-making and reward are differentially modulated. So we can see differences between conventional and rapid-acting antidepressants. The psychological effects seen in judgment bias, these are, we can differentiate between efficacious and non-efficacious antidepressants. And I've got other affective bias test data on that as well. And the prefrontal seems to be the locus. And then I'm going to finish off with this idea. And this is that we wonder whether what happens acutely is that we're seeing this, as people have talked about, this shift in excitatory inhibitory balance. But what we think is important, or I'm hypothesizing is important, is that this creates a therapeutic window. And in this window, what is happening is that these prefrontal circuits have been modified, and the affective bias circuit is kind of temporarily offline or not doing what it should be doing. And it's then that people can reactivate negatively biased memories. The affective bias is gone, and they can reconsolidate, and they become more positively biased, and that this is a protein synthesis dependent mechanism. So that's the kind of hypothesis we're just starting to generate. And I'll just finish off by thanking our funders and the people involved, and then I'll go back to that in case people want to ask questions. Sorry.
Thanks, Emma. That was really fascinating. Does anyone have any questions? Mike.
How do you induce the negative effect of contextual things in the ketamine stuff before you give the ketamine?
So we run the protocol exactly like we would for the learning paradigm. So on one day we pre-treat them with FG7142, which is anxiogenic, or CORT. There's a whole range of things, even acute restraint stress. 10 minutes restraint stress does the same thing. They all generate this negative bias. Which one no, it doesn't matter what. So ketamine affects all three that we've tested of those.
I guess just imagine what that effect might be like. It's not obviously something that you'd want, right? To have experienced something where something really bad happens, and now you want to do the really bad thing again. That seems like...
Okay, so probably what I didn't make really clear. So these aren't bad things. These are reward associations. They are just being negatively biased by the fact that they are being formed during a negative affective state. So the memory is that this digging substrate predicts me finding a sugar pellet reward, but when I'm feeling awful. So the memory is, I think there's two components. So there's the absolute bit of information that this predicts me finding nice food, and then there's the affective state part of it. And I think ketamine takes that affective state part offline. Or
I know I prefer to get the reward in the place where I feel awful.
Well, it's not the place, because the context is kept the same. So the context is always the same. So if something happens where and I mean, rats' lives are really boring. So I think they're reactivating those memories. I mean, what we want to do is reactivate the memories specifically. But I think they are naturally reactivating, possibly by us picking them up as well, may have part of it. But it is a rewarding memory. It's just got this negative bias.
I'm George. I was curious about one thing. For the differences between ketamine and MK801, are those looking at like 1 hour versus longer periods? Because there's sort of pharmacokinetic confounds there in terms of the very short acting ketamine, which have big efflux of glutamate, and then inhibitory processes coming in, whereas MK801 would have sort of longer excitatory effects.
So we tried really hard to match them from a pharmacokinetic point of view, but I do think you're right. I think it's quite hard to do that. What you're seeing is we do full dose response curves. And so we look until we get general disruption. And then but essentially we see nothing with them. So they're different pre-treatment times depending on what we would expect. So ketamines, we tend to use quite a long pre-treatment time, so an hour or 2 hours, because we don't want that acute dissociative bit anyway, because they won't perform the task. If they're too dissociated, they wouldn't do the task anyway. But you're right, I don't think we are spot on because of the pharmacokinetic differences, but we have tested a lot of different NMDA antagonists. And we do seem to see consistency. So we've just finished lanisamine, we've done memantine in both assays.
Thanks. I think unfortunately we're out of time now, I must say. Thanks again for a wonderful talk. Are we out of time? Oh, we've got one. We've got a question online, sorry.
You may present the decision-making right immediate reward. What about 1, punishment processing, and 2, delayed value/delayed discounting? Higher preference for immediate large reward perspective, long-term consequences may not always be positive choices. Presenting suicidal act.
So in terms of punishment avoidance, which I think is part of what that question was asking about, the original data we did was in a obtain reward or avoid punishment. And we do see pretty similar effects, actually. We haven't looked at more specifically, I think, what they're asking about delayed. No, we haven't looked at that. I don't know if anyone has actually looked at that with ketamine. Not sure. I'm not aware of any of that having been looked at, with whether it does shift their preference from immediate to delayed. But that's not what we're looking at here. So the reward is immediately delivered. So it's either high or low amounts. If I haven't answered it properly, they can email me and I'll answer it properly.
Is that out of time? Because otherwise I'll ask you. That is out of time. Okay. Thanks so much. Great, thank you. Is it Polly now? Yeah. Sorry, it's got she's just online, is she? Yeah. Do you want to put the mic? Yeah. So really delighted to welcome Polly Georgiou, who was from the University of Maryland when you registered, and is going to talk about corticotrophin releasing factor priming antidepressant response to our 6R hydroxyl ketamine. Has it gone forward? I don't know if you can. Can you go backwards or? How do you? Okay. Yeah. There we go. Oh yeah, press the green button. Yes. Okay, thanks, Polly.
Hello, everyone. Before starting, I'd like to thank the organizers for having me here. As I said, this work was done at the University of Maryland when I was part of the Gould Lab. Since then, I moved to University of Cyprus. It is a small island, for those that they don't know, in the middle of the Mediterranean. So today I will be talking about the interactions between corticotropin releasing factor, CRF, as you're gonna listen to me referring to today, and in regards with the response of ketamine and 2R6R agent K. So you've seen this a lot throughout this conference. So we all know here that ketamine, compared to the classical antidepressants, is very exciting because of the rapid effects as well as the sustained effects, as you see here. And then our group mainly concentrated on the investigation of the active metabolites of ketamine. And I'm not going to go too much into it because you already have seen this a lot in this conference. So we know that ketamine, the parent drug, initially is metabolized to norketamine and to dihydronorketamine, which doesn't cross the blood-brain barrier. But then norketamine is metabolites to several hydroxynorketamines, which the highest levels that is found in plasma in humans is the 2S6S and 2R6R agent K. Thus, initially we concentrated on the study of 2R6R and 2S6S. So just to put this into perspective now, 2R6R is actually under clinical trials. We are at the phase 1 study, and then hopefully if everything goes well, it will move on to the phase 2 trials. This is an effort led by the NIH and Carlos, among others. So there are several mechanisms that are suggested on how ketamine or its metabolite might work. And here in this, it's very intimidating, but basically what we have is 4 main mechanisms. The first one is through the disinhibition. So ketamine blocks binds on the NMDA, on the GABAergic interneuron, which then results into this increase in glutamate release. Then the second is through the blockade of the extrasynaptic NMDA receptors, or the blockade of spontaneous NMDA receptors that Lisa talked about yesterday. And the last mechanism is that I'm going to be mainly concentrating on is through the active metabolite agent K, which we know that it leads to increase in glutamate release, but we don't really know exactly how this is done currently. So back in the day when I was first starting my postdoc in the Bull lab, we came across this paper that showed that ketamine might be more efficacious in people that have higher anxiety and depression. As you see here in the Hamilton and the Mandra scale, that the people that they have anxious depression, they responded better with ketamine. So then we started thinking like why this might happening. And when it comes to anxiety, at least as a preclinical background, and also it's true in humans, in mind comes the HPA axis. So what is happening usually when we are stressed, we have the release of CRF from the hypothalamus, and then we have a cascade of events happening, which results in the release of glucocorticoids. And then in healthy humans, we have these recycle negative feedback loop to bring back the stress levels. Now in depressed patients, we have this dysregulation of the HPA axis, which results in higher corticosterone levels and higher CRF levels. And as usually CRF, how it does exert this effect is through binding on the CRF1 receptor. There is a CRF2 receptor, which I'm not going to be talking much today. But also in humans, it's evident that there is increased CRF concentration in the CSF in patients that they've been through child abuse or neglect, major depression, PTSD, antisocial personality disorder, and chronic stress syndrome. So we know that there is an association between these. So our initial thought is maybe CRF has something to do with the effects of ketamine. That's why we see this better effectiveness in people that have comorbid anxiety. And I want to mention though, like we usually view stress as a bad thing. I mean, obviously acute stress is not a bad thing. It's an adaptive mechanism to deal with everyday situations and is necessary for our proper functioning. Now, what we know about stress is that chronic stress is bad because it changes the neurochemistry of our brain and results to all the mental disorders that we are discussing here. I really like this graph here because it kind of shows that when we have tiny bit of stress, it's actually good. But then when you get to the higher stress levels, you go to these kind of maladaptive adaptations that results to other mental disorders. So you've heard a lot about the forcing test. I want to mention we don't use it as a model of depression. We've used it as an initial model for antidepressant efficacy. So it's the first pass behavioral experiment. Does a compound has any kind of effect or doesn't not? If then you get a positive effect on the forcing test, then we go ahead and we use other protocols to validate, in this case, ketamine. So that was a video which doesn't play. So usually what we expect to see is that animals that they receive ketamine, they struggle more. So they kind of have the tendency, they want to escape their current situation, while the vehicle animals, they just float on the water. So what we have noticed is when I first started doing the experiments was that we had a sex-dependent effect, sex of experimenter dependent effect. So what we've seen is that we consistently were able to get the antidepressant response of ketamine when it was administered by male experimenters. However, we weren't able to get it when it was administered by female experimenters. So that got us thinking a bit, and I'm like, is this something to do with stress? Is this something that we are doing wrong? Is it a forcing test? So we're like, okay, let's just test something else to see if this is true. And initially, we've tested this in the what we call learned helplessness paradigm. So what it encounters is the mice receive on day 1 an inescapable shock training. And then on day 2, you screen them. So these mice, they have the choice to escape. What we call helpless mice, even though they have the choice to escape the shock, they choose to stay in the same compartment and receive the shock. So we choose only the helpless mice in this protocol, and then we treat, and 24 hours we test. So what we expect to see is that ketamine, as you see in the male experimenters, with a female experimenter. But what we've seen in this protocol, the mice, the black mice, they will receive 10 minutes of physical stress every day, and then they will move to the next compartment, as you see in the schematic, and they will still be able to see and sniff the aggressive mouse, but they won't be able to physically get attacked. And so this phase acts as a psychosocial stress. Then we tested, tested these mice in the sucrose preference. And the mice that they received ketamine by the male experimenter, we could see that they actually have this recovery of sucrose preference. However, we haven't seen anything with the female experimenter. And we said, okay, maybe it's not treatment, but maybe can act as prophylactic treatment. So we reintroduce a small stress of 1 minute of physical stress, and then retested for the sucrose preference. And we see that it did have prophylactic effect, but only when it was administered by the male experimenters. So then after all these failures, we're like, what are we doing wrong? But then we started thinking that maybe we are not doing anything wrong. So there was a paper published in Nature Methods in 2014. This was a pain-related paper. But what they showed is that male experimenters, when handle mice, they induce higher levels of stress. And then these results in stress-induced analgesia. And they also showed this by measuring corticosteroid, plasma corticosteroid. So after that, we're like, okay, so what we might be seeing is an interaction between the stress of the mouse prior to ketamine administration, which somehow enhances the antidepressant effects of the compound. So to test this hypothesis, that's what I just said. So to test this hypothesis, we decided to infuse CRF into ICV into the brain by a female experimenter, and then 5 minutes after the infusion to inject these mice with ketamine. So when we did this, what we've seen is now we're able to replicate the male effect or the traditional expected ketamine effect, both in the force ring test and the Langerhans test. And we also performed these experiments with ketamine and Agent K, which seem to be behaving the same way. So that actually, it was a sigh of relief from our side at that point. And then the next step is like, okay, if we are able, if there is a true interaction between these, if we inject, pre-treat these mice with a CRF1 antagonist in mice that will receive ketamine by a male experimenter, we will be able to reverse the effects of ketamine. So we did this, and as you see, the CP526 is a CRF1 antagonist. And what we've seen is that the mice that they were treated with the CRF1 antagonist, they didn't show any antidepressant effects of ketamine in all paradigms that we tried, the Langerhans forcing test, as well as sucrose preference deficits induced by the chronic social defeat stress. So that was encouraging, but this is only behavioral outcomes. We wanted to see physiologically in our brain from data that we already know, we'll be able to see similar effects, or is something to do just purely behavioral. First, what we goes to the next one, but it doesn't show either.
Try with your computer.
Just turn off.
Yeah, that's next. If you can see, again, public.
Try with the arrows on the computer, it works for me.
It's completely. Oh, I'm sorry about that.
On that one either. That's what goes through it, and then it comes back.
They're amazing data. They're the best. You can trust me on that.
Yeah.
Tell that to my reviewers also. It works. Can you see it on screen? Can I plug my USB here?
Yeah.
Yeah, it's.
Sorry. Yeah. Maybe, I mean, it might, I don't know, yeah. Should we just keep going? Yeah, maybe that, sorry. Can you talk us through that?
Well,
It's quite tricky.
so what it was supposed to be here, it was that we did show what Carlos also described in humans, that we've seen when ketamine is injected, that we see this increase in gamma power in high frequency oscillations, which is a good readout for humans as well as animals for the efficacy of ketamine. And then we were able to block this effect with the CRF1 antagonist, further suggesting that our effects are not only behavioral, but we've seen also brain-specific effects. Yeah, so here, it was supposed to be that, following up on Lisa's work that she showed the increase on AMPA-mediated potentiation in the CA3 to CA1 pathway. We have the ideas that maybe CRF is actually priming the effects of Agent K to be able to exert these effects. So we applied, we wash in CRF with Agent K simultaneously. And then, but what we've seen is that we've seen the expected potentiation with Agent K, but we haven't seen any increase in the potentiation with CRF. Then wanted to move one step further, and there is another pathway that is not very well discussed or mentioned in the hippocampal pathway that we know is more sensitive to stress-related effects. So this is a projection from the entorhinal cortex to the CA1. We've used exactly the same protocol as before. So washing simultaneously CRF and Agent K and test whether we see this increase in potentiation. So Agent K, we know that doesn't increase AMPA-mediated potentiation in this specific pathway. But what we've seen with the washing of simultaneous CRF and Agent K, we've seen increase in the AMPA-mediated potentiation, suggesting that actually this is a pathway that might be responsible for our effects and might be important for ketamine's antidepressant effects. And then we were able to block the potentiation with the CRF1 antagonist. The next question is, okay, we applied simultaneously CRF and Agent K, but the known projection between entorhinal cortex and CA1 is glutamatergic. So it was never reported before if there is a CRF projection from entorhinal cortex to CA1. So to first see if do we actually have this projection, we perform a tracing study. We've used the CRF cream mouse line and then injected a specific retrograde virus that is absorbed only by Cre-expressing neurons. So what it will do, we will be able to see projections everywhere in the brain that have terminals afferents into the CA1. So when we did this, and then we specifically looked in the entorhinal cortex, I don't know how clear you can see the images, but we can clearly see that there are projections, CRF projections from EC to CA1. Then we started looking a bit more on the literature. So as I mentioned, this pathway is specifically involved in stress, and what has been shown is that there is a decrease in the synaptic strength of the circuit following chronic stress. Also, EC, entorhinal cortex, is involved in stress responses following exposure to acute stress and development of fear memories, as well as that is involved in condition odor aversion and context aversion, which is going to be more related with our stress model. To test whether actually we've seen a decrease in this activity or increase in this circuit activity following stress, in vivo, we've used the fiber photometry. So what we do in this system is that you inject a calcium sensor and then you implant specific fibers, optic fibers, and then when you shed the light, you will be able to record the calcium emitted by the specific sensor in the specific region. So this is an indirect measure of neuronal activity. So what we get is this fancy system of many lenses and filtering systems, and that's on the right side is what we see as an output. And then through multiple filters and smoothing, we are able to isolate these events and then analyze them. So this is okay. So. It wasn't supposed to be like this. So what it shows is that this circuit, we've seen increase in vivo activity when the mice are exposed to the male scent. compared to the female send or control send, suggesting that this circuit is actually engaged in stress mediated events. And then to further confirm that it is necessary for stress, we've used NRED. So we injected the inhibitor in NRED in the entorhinal cortex, and then injected CNO prior to our behavioral experiment. So using this approach, we are able to specifically inhibit this projection. And what we've seen is when the mice were given a choice between water and male scent from a swab, we usually see what you've seen there with the cherry, which is our control, and the inhibitor in red that they receive vehicle, that they have this aversion to the male scent. However, when we injected CNO, so inhibiting this projection, we see that they don't show aversion anymore, and they actually show preference. So we demonstrate that this circuit, yes, it's important for stress. And also what we've seen with ketamine, it might be actually showing that it's specifically involved in ketamine's antidepressant responses. To test that, we've used optogenetics, and how basically this technique works is that we have the specific opsins proteins that they are activated by blue light. So when we inject these opsins, they are getting absorbed by our neurons that express CRE, and then we will be able to specifically manipulate the CRF entorhinal cortex to CA1 projection. So what you can see here is that with the traditional electrical stimulation, we basically stimulate every neuron that is in the specific region. With the light stimulation, if we don't have expression of channelrhodopsin, which is our protein that we've used, you don't activate any of these neurons. So as you see on C, we will be able to specifically activate the neurons that express channelrhodopsin. So initially, before we do anything else, the main question was, what is this projection? Is it glutamatergic? Is it inhibitory? Is it anything else? So using this approach, we, in combination with whole-cell electrophysiology, basically we stimulated the terminals of this projection and recorded on the CA1. And then after our recording, we applied glutamate inhibitors. And what we've seen that we were able to completely block the effect, suggesting that it is an excitatory projection. So moving on, using a similar approach, but this time in vivo, we stimulated the terminals of this projection for 5 minutes prior to ketamine administration. So, and then 24 hours, we tested them in the first swim test. And what we've seen is that the animals that they receive a combination of stimulation of this projection and ketamine were able to induce the antidepressant effects of ketamine in the first swim test. So this is kind of an outline of what we call the CRF state on and CRF state off. So what we are suggesting is that when we have an acute stress just prior to ketamine administration, we have this increase in CRF from the entorhinal cortex to the CA1. And then with the administration of ketamine, this enables this increase in glutamate, which results in the antidepressant response. However, when we don't have this increase in CRF, ketamine or agent K is not able to exert this increase in glutamate, which is, we believe, responsible for the antidepressant response. So this is more like a schematic of the working model. So in our, male send, it doesn't have to be the only stressor. Our point is that we need an acute stressor prior to ketamine administration, and that might enhance ketamine's efficacy. So what we believe is happening, we have the initial stress, so we release CRF, which activates the CRF1 receptor, which in turn interact with agent K to increase glutamate release. And then we have the increase in BDNF and other protein synthesis, which will eventually result to the increase in the implementation in the recruitment of AMPA receptors on the synapses, which is responsible for the final antidepressant responses. So I'd like to thank all the people that were involved in these studies, as well as the funding. And I'm sorry for the issues with the slides.
No, thanks very much. Thanks very much, Bonnie, and for dealing with the technical issues so gracefully. We've got time for some questions, I think. Has anyone got any questions? Oh.
Hi, Julie Hietmius from Stanford.
Could you speak up, please? We've had a message that the questions are not coming over very well for the online audience. So please shout.
Okay,
So, hi, Julie Hietmius from Stanford. Really nice to see this, and we've actually done this paper in our journal club. Super pertinent for our research. Have you guys tried any crossovers with the male-female experimenter? Just for like practical reasons, it would be good for us to know if like people like me could be involved at any stage.
Yeah. So we tried this, but we've seen that somehow this effect is persistent. But what we did is, if you change the strain of mice to a more anxiogenic or more stress susceptible strain, like the BALP-Cs or the 129S, then it doesn't matter who injects, male or female, then you get the effects. So our suggestion is, when you see these effects, probably it's advisable to use a more stress susceptible strain to do that. Yeah.
Any other questions? Could I ask, so did you set out, originally you didn't set out to look at the male and female experimental effects?
Well, we didn't. So the paper, the Nature paper was out, and then we were validating the new batch of the compound, and then we weren't able to get any effects. So that was initiated the whole project of figuring out what happened and why, and then we bumped into it, and then we started actually talking with other researchers, and it's been around for quite some time. It's just people that didn't want to publish it.
It's amazing piece of serendipity.
Can I ask a dumb question from somebody who knows nothing about animal work? I mean, if male and female experimenters have this different effect, shouldn't they be togged up so that there's no scent when they work with the animals? So you've got kit that stops the scent. Because my impression is that different men smell differently to each other.
Yeah.
Quite a wide range.
Yes. So there are other factors that can affect. Yes, different scent, people smell differently. But what we've noticed is that when you eliminate any kind of smell, still you don't get any antidepressant effect. So it seems that this initial stress prior to administration is important. Because when you inject under the biosafety cabinet, which you basically eliminate almost any smell, mice still don't respond. In our hands, at least, it didn't respond.
Do you think this is a sufficiently reliable sort of stressor that you can rely on this, even given the range of different smells?
Yes, I mean, we did test several experimenters. I didn't show the data, but throughout the manuscript, we have roughly 8 to 10 experimenters for each experiment. So I cannot say that for everyone is the same effect, but it seems that overall there is an effect with a stress effect with the male experimenters, some more than others. But yeah.
I think Sarah and then Ben, yeah.
What if your female experiment where clothes were by a man before?
So we haven't tried this, but other labs have, and they do say that they were able to get effects, but we haven't tried it. So, but from what is going around, it seems that yes, you might get away from it if you want to wear your, like other people's clothes, I guess.
And then, yeah, sorry, one quick last question from Ben. Yeah.
Is there a difference between male and female rats? Are they all female?
Sorry?
Are they all female in there?
No, they are male and female. So
There's
no, we didn't see any difference. It seems to be pretty consistent.
Oh, well, thanks again as well, and especially given all the stress. Thanks. And our next speaker is joining us online. Oh, there we go. Yeah, so we have Dongying Fu joining us from Janssen Pharmaceuticals, who's going to talk about the SUSTAIN-3 study, so the long-term safety study of S-ketamine. Are you there, Dongying?
Yes, let me share my screen. Can you hear me all right?
We can't see you.
Okay, I will turn on my camera and share properly.
Fantastic.
Okay, is the screen all right? Can you see properly?
Yeah, you can see your slides. Yeah.
Okay.
I can't see your face, but you can see her online. Okay.
Okay, can you see my face too?
Yeah, you can online.
Okay.
We can't hear, but.
Okay.
Okay, thanks.
All righty.
There we go.
Okay, thank you. Yeah, this is Dongjin Fu from Janssen, and so I'm going to present clinical data, follow the two wonderful preclinical presentations before me. So this is my disclosure. So I'm the clinical leader for S-ketamine program, and I'm a full-time employee for Janssen. So the S-ketamine, intranasal S-ketamine has been authorized in 2 indications. The first indication is for TRD, and the second indication is for the rapid reduction of depressive symptoms in patients with MDD who have acute suicidal ideation or behavior. In other words, for in a psychiatric emergency. So the study update I'm going to present today is SUSTAIN-3, which is being conducted to evaluate a long-term safety and efficacy data in S-ketamine treatment with patients with TRD. And this is an open label extension study that provides patients who joined our pivotal phase 3 TRD study to receive intranasal S-ketamine treatment until the product is approved in the respective countries and accessible through the local healthcare system, or until the end of this year, the study will complete. So patients from one of the 6 parent studies had to join this study. The first patient was entered in June 2016, and the last patient entered the study in February 2019. And the data I'll present today is from our December 2020 data cut, which has 4.5 years exposure from the study initiation. My colleague Carla Canuso presented at this conference last year an earlier interim analysis, which only has safety data at the time. So the data cut I have today has 6 more months of data and efficacy data as well. So as I mentioned, patients are entering from the 6 parent studies. They could enter into the 4 weeks induction phase or directly to the optimization or maintenance phase of the study. So it depends on their status as a parent's study. If they were non-responders from the parent studies or relapsed during the SUSTAIN-1 study or had a gap on intranasal S-ketamine treatment in the parent study, they would enter the induction phase. And responders from the parent study would enter to the optimization and maintenance phase. So in the induction phase, patients self-administered S-ketamine as a flexible dose twice weekly for 4 weeks. In the optimization maintenance phase, patients received S-ketamine as a dosing interval that was individualized to the severity of their depression. Dosage was 56 milligram or 84 milligram. For those who are older than 65 years old, patients can have the 28 milligram. Safety assessments include adverse events and adverse events of clinical interest, and efficacy assessment includes a clinician-reported outcomes such as MADRS and CGI-S, and patient-reported outcomes on their depressive symptoms, functioning, quality of life, and their treatment satisfaction. And all patients are also treated with their background antidepressant. So this is a global study that enrolled 1,148 patients from 28 countries in Europe, North America, South America, and Asia. The ages patients were from 18 to 83 years old, with over 10% was 65 years or older. And 2/3 were women, and about a quarter of them had a history of hypertension. So 458 patients entered the induction phase. Of them, over 90% continued into the optimization and maintenance phase. So we have 8% discontinued during the induction phase. And the top reasons are on the left top box were lack of efficacy in 2%, and non-responders in 2%, and adverse events in 1.5%. And 690 patients directly entered into optimization and maintenance phase after their parent studies. So we have a total of 1,110 patients enrolled in the optimization maintenance phase of study. Some of them were from induction phase. So of this over 1,000 patients, 30.8% discontinued by the time of this interim data cut, and 5.3% due to adverse events, 4.4% due to lack of efficacy, and 4% withdraw consent. And the majority, the other 15%, were due to other reasons. For example, their symptoms improved, they didn't want to continue the treatment, their scheduling, logistic conflicts for coming to clinic, frequently. They moved to different places, starting new job, and patient choice, etc. So because the study was designed to provide long-term access, and when the product is available in respective country, patient would be exited, so they can be treated as part of the standard of care with ketamine. So since the December 1st, 2020 data cuts, and patients from US, Sweden, France, and Belgium had exited study because products are available but locally. So right now we have 471 patients who are still ongoing in the study and until the end of this year. So at the interim data cut, the median exposure to ketamine in the SUSTAIN-3 study was 37.7 months, and the mean exposure was 31.5 months. This resulted in a total exposure of 2,779 cumulative patient years for ketamine treatment. So this bar chart showed the duration of cumulative intranasal ketamine exposure. This includes their exposure in the parent study. So you can see over 1,000 patients were on ketamine treatment for at least 6 months. 866 patients were on for 2 years or longer. We have over 700 patients were on treatment 3 years or longer. And on the right part, 173 patients were on 4 years or longer. So since we still have 471 patients ongoing in the study, the number of patients with longer duration is expected to increase when we have the study end this year. So now in the study, patients were treated with flexible dose of intranasal ketamine, which is determined by the investigator based on efficacy and tolerability. Investigators could also adjust dosing frequencies when they plan for the next dosing session based on the CGI scores. And if it's moderately ill or more severe, usually they increase dosing frequency. the flexibility of dosing was designed to mimic clinical practice. So this table shows the final dose in each treatment phase by the interim data cut. So you can see in the induction phase, both induction phase and optimization maintenance phase, 84 milligram, majority of patients has 84 milligrams as their final dose. 21 to 31% of patients in each phase received 56 milligram as their final dose, and 1 to 2% received 28 milligram as final dose. Again, which is only available for patients 65 years or older. With respect to the dosing frequency determined by investigators, most of the participants, investigator planned to dose them either weekly or every other week. During entire study, with a small percentage of participants were dosed every 4 weeks. So this dosing frequency pattern were pretty consistent for the duration of optimization and maintenance phase. So for the next several slides, I will present the efficacy data. So this figure shows the clinician-rated depression scale MADRS change over time. So the MADRS mean scores are reduced from 28 at the beginning of induction phase to 16 at the end of induction phase, with a mean change of 12.8 in MADRS. And this reduction persisted during the optimization and maintenance phase with a mean change about 1 point. So you can see the figure flat over the 4 years of treatment. And at the end point, 35.6% of patients achieved remission, which is defined by a MADRS score 12 or under at the induction phase, and 46% patients achieved remission at the end of optimization maintenance phase at this data cut. Similar efficacy results were also seen on patient-reported outcomes. So here is the patient health questionnaire, PHQ-9, a 9-item patient-reported outcome measure assessing depression symptoms in the past 2 weeks. So the score range is from 0 to 27, with higher scores indicating greater severity of depressive symptoms. So the mean PHQ-9 total score was 15.4 at baseline of induction phase, which indicated moderately severe, and PHQ-9 total score decreased, which means improved with esketamine treatment with an induction phase endpoint mean score of 9.6, indicating a mild symptoms reported by patients. The mean change from baseline induction phase to the endpoint is 5 points in the total score. The PHQ-9 score appeared to be maintained during the optimization maintenance phase of treatment, as the score are pretty flat. We also have patient assessing using the European Quality of Life EQ5D5L, which is a standardized instrument for use as a measure of health outcome by a patient. So the EQ5D5L descriptive system has 5 dimensions: mobility, self-care, usual activities, pain, discomfort, and anxiety, depression. Patients answer the questions based on their current health as of today. So each of the 5 domains is divided into 5 levels of perceived problems. Level 1 is no problem. Level 2 is slightly problem, all the way to level 5 is extreme problems. So this slide, the y-axis shows the proportion of patients who reported problem in each of the 5 domain at the baseline. Green bar is the baseline, and red bar is endpoint. The left bar chart is the induction phase, and right bar chart is optimization maintenance phase. At the end of induction phase, fewer patients reported problem on self-care, usual activities, pain, discomfort, and anxiety, depression. For example, if you look at the bar of usual activities at beginning of induction phase, 86.6% reported they had problems doing their usual activities like work, study, housework, family activity, etc. at the baseline of induction phase. And at the end point of induction phase, 69.2% of patients reported has problem doing usual activities. So it's shown in the right side of this slide, the levels of quality of life maintained for the 5 dimension during stable during the at the end of a maintenance phase. Okay, so another patient-reported outcome measure was Sheehan Disability Scale, the SDS. The first 3 items of Sheehan Disability Scale assess the disruption of work, school, their social life, and family life, home responsibility, with a recall period of past 7 days. Patient use a 0 to 10 reading scale. So in this slide, we reported the remission defined by the SDS total score, which if it's 6 or less, or every single item score is 2 or less, which means mildly problematic or functioning impact. So this is bar chart shows during the open label maintenance phase, about a third of patients were in remission based on their self-reported SDS scores. So in the remainder of my talk, I will review safety results. So this table shows the common adverse events with a rate of 10% or higher occurred in the sustained study by different treatment phase. So the top part is induction phase. The bottom part is optimization and maintenance phase. So consistent with the safety profile of esketamine, many of the adverse events, such as headache, dizziness, nausea, dissociation, somnolence, and dysgeusia or bad taste, were transient, and most 96.7% of this occurred on dosing days and resolved the same day during the combined induction and optimization maintenance phases. Because of long duration of the study, over 4.5 years for the interim data cut, we also observed commonly occurred medical events in the population, such as the nasopharyngitis, flu, upper respiratory tract infection, and urine tract infection. So this slide shows the patient who discontinued the study treatment due to adverse events. So the list here shows events that occurred at least 2 subjects, and there were discontinuation due to blood pressure elevation, dissociation, worsening of depression, etc. And next couple slides, I will show data of clinical interest. Sedation is one of them. So overall, we observed 7.8 of patients reported sedation as adverse events. And 99.4% of the sedation events occurred on their dosing day and resolved the same day. There was no serious adverse events of sedation, or there's no AE of sedation that led to discontinuation of study treatment. We did not see any respiratory depression observed. Sedation was also assessed by the Modified Observer's Assessment of Alertness Sedation, or we call it MOAS, for the first several years of the study. And the MOAS score decreased usually within 15 minutes of dosing and plateaued at 30 to 40 minutes and then returned to near pre-dose level by 1 hour. Dissociation is another clinical interest event, which is reported by 24.4% of patients, and 3.2% of patients had a dissociation event lasted longer than 2 hours. So that's what I showed in this figure on the left. Rates of dissociation that was longer than 2 hours and over time of the study duration. So initially there's the weekly rates of 1 to 2% in the induction phase, and then followed by about 1% monthly rates, and the later part we plotted a quarterly rates in optimization maintenance phase. So they're under 1% rates as well. So 99.8% of dissociation occurred and resolved on the day of dosing. There's no serious events reported related to dissociation. We have fewer subjects required concomitant treatment, and 0.4% discontinued due to dissociation. And this slide showed blood pressure related events. Overall, 79% of patients experienced an adverse events of blood pressure elevation during the study. The figure showed the AE rates over time, initially weekly rates plotted, followed by monthly rates, and then quarterly rates. So the rate of blood pressure AE is pretty stable throughout the entire study. And most 96% of blood pressure elevation occurred and resolved on the day of dosing. 6.3% of patients had markedly elevated blood pressure, which is defined in our protocol as systolic equal or greater than 180 millimeter mercury, or diastolic equal or greater than 110 at any time during the study. All these occurrences were transient and resolved the same day. So we have 0.6% patients discontinued study due to elevation of blood pressure. There are cases reported in the literature of bladder toxicity, including interstitial cystitis after prolonged recreational use of high-dose esketamine ketamine, not esketamine, for the ketamine abusers reported in literature. There has been no cases of interstitial cystitis reported in SUSTAIN 3 study, which has exposure up to 4.5 years long-term treatment. There were cystitis-related events such as dysuria, micturition, urgency, etc. And those events were mostly of mild in severity, transient and self-limiting, and considered potentially suggestive of infectious etiology. We did observe UTI in about 13.43% of patients, and we did a careful look to see what is the background rate of urinary tract infection in patients with TRD. So the database analysis or claim database analysis showed 14.4% with TRD, had UTI in a year yearly rate. So our reporting observed rate is pretty similar to what is reported in the background of TRD patients. This final safety slides show the serious adverse events, which is reported for 14.9% of patients. And for the long duration of study is expected. So the serious adverse events, just a reminder, are the events that require hospitalization or resulting in death, life-threatening, or considered medically important by investigators. So the only SAE reported in greater than 1% of patients were depression or worsening of depression that required hospitalization. Investigators consider the majority of SAEs to be doubtfully or not related to esketamine treatment. There were 5 deaths occurred by this interim analysis, including 1 complete suicide during induction phase, 4 days after the last dose, and one patient died of multiple injuries due to hit by a car while riding a bike 6 days after last dose, and 1 patient died of MI 6 days after the last dose, and 2 patients died due to COVID infection. None of the deaths were considered by the investigators as related to esketamine. So this concludes the data presentation. So in summary, the SUSTAIN-3 study is an open label extension study to evaluate efficacy and safety after long-term intranasal esketamine treatment. And esketamine treatment is on top of their background oral antidepressants. So this represents a largest cohort with the longest duration of intranasal esketamine treatment. During induction phase of twice weekly esketamine treatment, patients showed a decrease in their depressive symptoms, both measured by the clinician-rated MADRS scores, and the improvement was also shown or seen by the patient-reported outcomes on depression and their functioning. And the improvement appeared to be maintained during the optimization and maintenance phase. And most clinical relevant safety findings were mild or moderate in intensity and were transient. There were no new safety concerns identified with continued intermittent esketamine dosing for up to 4.5 years, which is comparable with the existing well-characterized safety profile of esketamine that has been observed shorter-term studies. Specifically, long-term exposure to esketamine yielded no additional concerns or trends related to cognition, suicidality, drug abuse, dependence or withdrawal, or interstitial cystitis, renal adverse events, or hepatic adverse events. I didn't report all of the data because my colleague Carla Canuso presented key data last year during this conference. So the study will come to conclusion by the end of this year, and we will be releasing our final study results next year. So I would like thank our investigators, our participants of the study. It has been a long treatment, long journey for the study, and many efforts has put in to the study and provide access to the patient. And I'd like to thank my colleagues. I know some of our investigators are also in the audience for this conference, and thank you for your attention.
A really fascinating talk. We've got time maybe for just 1 or 2 quick questions. Anyone? Hi.
Hi, Esther Hagai from Flexio. I just wanted to understand.
Can you speak up, please?
Yeah, I just wanted you to confirm that you enroll non-responder to the induction and responder to the maintenance, regardless of their initial allocation to placebo or ketamine in the parent trial.
Right. So if they are non-responders, they usually enter to induction phase, right? So if they're responders, they enter to optimization and maintenance phase. And for those who entered in induction phase, at the end of induction phase, if investigator evaluate benefit risk, and there is a benefit for patient to continue the study, they would be transitioned to optimization and maintenance phase.
Yes, but the response was you entered any patient regardless of whether it was initially randomized to placebo or ketamine.
Correct.
Okay.
Correct.
Thank you.
Yeah, there are placebo patients enter to induction phase, and placebo responders could enter optimization and maintenance phase, yes.
Hi, Toby Martin, Mindful Health Solutions in San Francisco. So we're examining a case series from our clinic right now, about 120 of our patients who have been on Spravato for 6 months. So more of a real world situation. And what we're seeing is looking interesting and a little different from the data here. I'm wondering if you can comment on it. One thing, the main thing that we're finding interesting is that the nadir of the PHQ-9 in our population seems to be occurring around week 16. So a solid 4 months of treatment, we're continuing to see a slower response trajectory than what we've seen in Transformer and Sustain. And I saw that the data here, it looked maybe closer to week 4 to 8 in the Sustain 3. I'm wondering if you have any thoughts on different response trajectories, and is that something you might go back and look at, looking at mediators and moderators?
Yeah. So that's a good point. So for the Sustain 3 study, of course, patients were in the parent study before. So, and here the trajectory, it included their prior treatment and then continue the treatment through the study. So we also look at the Sustain 2, which is open label 1 year treatment. It's the interesting point. We can take a further look on the trajectory of responders, both in their symptomatology and their functioning. Usually they are correlated, and not everybody respond, but we see rapid response, and then they continue. Some patients continue slowly improving through the several weeks or a couple months, etc. Yeah, different trajectory of different patients we do see.
Rupert's got one quick question.
What was your treatment of the dropouts?
Can you repeat the dropout question? I didn't quite get it.
What was your treatment of the dropout data?
Yeah, the treatment of dropout data. So from the study perspective, when they discontinued study, we do not collect additional information afterwards. So we don't have systematically data collected after dropouts.
But their data were included, the data up until the point of were included.
So now some of our parent study, short-term study, we do have the 4 weeks treatment and followed by 2 weeks. Some of them are 6 months of collecting data when they are on regular standards of care treatment, right? Not for Sustain 3. So for those data after treatment and then followed by a standard of care, we are observing as part of the safety assessment to see if there's any, for example, withdrawal symptoms and rapid deterioration, but we did not observe those safety events.
Okay, yeah, we're a bit over time, so there's some questions online, I think, perhaps, no, but if you're able to answer them or ask questions of Dongying in the chat on the speaker forum.
Okay.
Yeah, so thanks again for your
Thank you.
talk. And very good meeting. And now we have Rebecca Price from the University of Pittsburgh, who's going to talk about an automated cognitive training battery and how that can extend the antidepressant effect of ketamine. So do you want to pop that one on?
Okay, sound good? I have to press it. Okay, it's not doing anything. Okay, is it not close enough? Okay. Okay, so my name's Becca Price. I am here from the University of Pittsburgh. I'm a clinical psychologist by training. I just want to start by expressing really sincere gratitude for inviting me today. I was really blown away when I got an email from Rupert and Sarah. It must have been within days of changing my clinicaltrials.gov status of recruitment to completed. I mean, it might have been within hours. And I got this email saying, do you think you'll have something ready for Ketamine 2022? And I said, I hope I'll have something worth saying. So here I am. So I just really am amazed by the effort that's been put in to create this community. And it's a privilege to be a part of it. All right, so my disclosures, I have for the first time an actual disclosure, something I've never had before, which is that I am named as the inventor on a provisional patent that was filed by my institution relevant to what I'll be presenting on today. And the funding for what I'll present on is from NIH. So my project was inspired by two threads that have both been part of my research program for some time now. I don't need to belabor the exciting elements of rapid acting antidepressants when those came on the scene, and in particular intravenous ketamine, which we all are here to talk about. But the other one for me is the potential of automated computer-based treatments to potentially radically increase patient access to care and reduce costs, minimize burdens, and aversive consequences. And my project that I'll describe is really aimed at attempting to synergistically combine the advantages of both of these approaches and create something that's both rapid and durable. So the study in essence is about reframing ketamine's impact as a short-term plasticity boost for learning and to facilitate uptake of new learning. So I'm speaking about neuroplasticity really in a conceptual framework as a broad umbrella term. Of course, we've already heard a lot about the nitty gritty and all of the complexities of what that actually means, but I am interested in this idea that the brain's capacity to flexibly adjust and reorganize itself in response to our ever-changing environment is somehow enhanced by ketamine. And so, of course, the classical findings from this literature, as Chadi outlined very beautifully in his 2015 review, have shown that in animal models, if you expose to chronic stress, you'll see a withering away of some of the points of contact, some of the spiny synapses on dendrites in key regions implicated in affective regulation, like the medial PFC, and in limbic areas like the hippocampus. And the idea is that depression and other psychological states involves this synaptic disconnectivity, and that recovery from depression and the treatment target is about repairing that deficit. But as a psychologist, I'm really fascinated by how that might map on to the types of things that patients describe when they tell us about how they get stuck in a limited space of options and just can't see a way or actualize a way to have a more flexible behavioral approach, a more flexible cognitive thought patterns in response to their environment. So in my research program, I've been working from this kind of conceptual framework regarding this construct of neuroplasticity and how it might apply to a wide range of psychological conditions and kind of how it might propagate up the system at different levels of analysis, manifesting, for example, as disrupted function and connectivity within prefrontal and limbic circuits that we might see in fMRI measures, and also in the information processing patterns, such as part of what Emma had touched on earlier in her talk, these rigid negative biases that we can see in patients when it comes to attention, memory, the way they represent themselves and their self-attributions, decision-making, and more. All of these kind of show these negative and kind of stuck patterns. So that then gives us an understanding of how an individual who enters each and every environment with that sort of framework and this way of processing the information available in the environment might then yield affective states and the patient-reported symptoms that we see chronically in these conditions. So I had the great privilege to work with the late, great Ron Duman on a 2020 review paper where we tried to outline how this might all be sort of different pieces of the same puzzle. But what I'm most interested in is to use this as a roadmap to creating novel strategies that get people well quickly and hopefully keep them well over the longer haul. And so over the past 10 years or so, I've been drawn to focus on integrative or synergistic treatments, where the idea is that we might get a stronger or more efficient and more enduring positive impact by tackling multiple levels in this process simultaneously. So in my lab, we've been using multiple methods in an effort to open a window of plasticity. So some of my studies, we use transcranial magnetic stimulation to do this in a more localized focal way. But in the studies I'll describe today, we've used intravenous ketamine and then tried to inject into that window of opportunity useful opportunities for learning and skill acquisition that we think will be protective over time against the return of symptoms. So in terms of ketamine's rapid impact as a standalone treatment, of course, we've heard many of these studies, and including the very seminal work that showed us these effects. But if we fast forward about 20 years now, we are recently in the late stages of compiling together all the data at the individual patient level that we can get our hands on for every RCT that's been done over those past 20 years, where a depressed sample received either ketamine or some sort of placebo. So working with statistician collaborators in my department, we've gotten analyses on 17 RCTs conducted in 8 countries over 4 continents, and we can really leverage this individual level data in a way that's not possible with standard meta-analyses where you have 1 data point per study. Now we have 1 data point per patient in these 809 patients. This would be a whole nother talk that I'm not giving today, that I'm not signed up to give today. So I'm just really just highlighting that overall, this response rate of 46% is what we're seeing overall in these 17 RCTs, 27% remission rate. So this is kind of where the field now lies in terms of the overall efficacy that we see at the rapid time point. And this is one example of a moderator that we've identified through this approach, because we are able to look very exhaustively within this data set for the characteristics that might enhance the effect, the differential impact of ketamine versus placebo. And this one that I'm highlighting here is that higher levels of treatment resistance are actually associated with greater differential effect of ketamine versus placebo across all of these RCTs. Although both groups do show separation from placebo, I should say. Okay, so if we think of neuroplasticity as being what we want to target, we have some very interesting animal neuroscience data that's been around for quite a while now, looking at how ketamine might induce these rapid synaptogenic effects in the medial PFC. So that you see, starting from the effects of chronic stress here on the left, if we see the synapses reduced by that stress here in the middle and then rapidly restored 1 day after an infusion of ketamine. A more recent paper from Moda Sava in 2019 used a really interesting optogenetic approach where after seeing this sprouting and this regeneration of synapses following ketamine, they were able to optogenetically selectively delete just those synapses that had been sprouted by the ketamine. And when they did so, they saw reinstatement of depressive-like behavior in at least one of their behavioral tests. So just showing the importance of these synaptogenic processes. So much of this insight comes from animal studies. And I think that we still have so much to uncover with respect to how these different pieces of the puzzle might actually all fit together. And so this was one of the goals of the R01 that I'm describing today, was to kind of think about this and collect information very integratively across a number of levels. It's a really mountain mountainous trove of data that we're just taking the lid off of. So I'm only talking today about very briefly touching on just one of the indices that we've collected, which is what I think of as being the closest thing that we have to those animal studies that I just described in human patients. And this is a measure you can get from diffusion weighted imaging. It's called mean diffusivity, and it quantifies, usually DTI we think of as being useful in white matter, but you can use it in gray matter to look for microstructural changes that might reflect things like the sprouting of new little synapses on those dendrites. And so previous animal work had used this approach and showed that you can find these microstructural changes within limbic regions like the hippocampus after training animals in a relevant paradigm. Just 2 hours later, re-image them. You can see these changes in the mean diffusivity marker that are correlated with other neuroplasticity markers like synaptic vesicles, astrocyte activation, BDNF expression. So it suggested we can localize this neuroplasticity in vivo over short timescales. And in humans, one of my collaborators, Tim Keller, used this measure in a study where half of the individuals were given a 45-minute training session in a spatial learning kind of maze game and scanned before and then just after the training. And this, in the group that received the training, this measure picked up on what the authors interpreted as the sprouting of new microstructure or synaptic connections that represents that learning that they just gave them within that 45-minute window, whereas the control group doesn't show this. And you see these are the marker of mean diffusivity is always going to be inversely related to kind of the density of microstructure in the region. So in our study, we had 154 unipolar depressed patients. They had to have failed one FDA-approved antidepressant. They were able to continue concurrent antidepressant treatments. They had to have a baseline MADRS score of 25 or greater. And in this study, they were randomized in a 2-to-1 scheme to receive either a single infusion of ketamine using the standard protocol or saline. So with a really talented and wonderful postdoc in my lab, Jared Kopelman, we've been looking at this mean diffusivity marker in relation to treatment outcomes in our study because we have the measure at baseline and then again at 24 hours. So this is showing the change from baseline to 24 hours in the mean diffusivity versus QID scores. And so what we see is that in the ketamine group specifically, changes in this marker of microstructural density in the left medial PFC here and in the left amygdala are tracking positively with symptomatic outcomes following ketamine. So the more of this kind of density sprouted up, the better the patients are reporting that they're feeling. And similar effect in the right medial PFC as well. So right in these regions that have been so heavily implicated in the animal literature. Now, there's a caveat that we do not see these types of patterns in every region that we've looked at, including the hippocampus. We're not seeing this type of effect there. And we also are not seeing a main effect of ketamine versus saline on this marker. So it's really about the individual differences. Am I doing that? Okay. So that's a peek at one of our levels of analysis. Now I'm actually going to back up to some earlier work that we've done where we tested how ketamine might impact things at this information processing level, and specifically the idea that ketamine might rapidly loosen up and allow a patient to get kind of unstuck from rigid negative biases pertaining to their own self-worth. So for this, we've used the implicit association test, or IAT. So you can see in this example here, in this particular study, we were interested in suicidal cognition. So we looked at associations between oneself and suicide-related constructs like escape. And so in this sample, the patient must press the left key if they see a word in the middle that's either related to me, myself, or to escape. And then in other blocks, we swap the pairing so that now they need to press with the same key for me words or for stay words. And it's the differential between performance on those two blocks and the speed of performance that gives us a behavioral performance-based index of how tightly associated in the mind two ideas are. So we had shown all the way back in 2009 in a very, very small open label study where we first described the impact of ketamine on suicidal symptoms. In that same study, we also used the IAT and found this rapid drop at 24 hours post-ketamine in the strength of association between escape and me. And this association and the performance on the IAT, as well as on a death equals me IAT, both were correlated with the degree to which suicidal symptoms were reported as being decreased following ketamine. So this was really, really small sample, but later we did replicate this in a RCT, much larger sample with a midazolam control, and found that there was a specific decrease in this IAT measure of self-associations in the ketamine arm. So this led us to a hypothesized window of opportunity in thinking about targeting self-associations and opening up plasticity within self-associations. So if we think of depression as involving this sparsely connected network, where maybe you have a lot of really well-trodden pathways for things like self-loathing, but you don't have a lot of different avenues that get you from me to good or worthy. You know, one way that I think about what we do in cognitive behavioral therapy is kind of piece by piece, painstakingly building those types of roads. But I think of ketamine as kind of airdropping in a whole bunch of bits and pieces of road very efficiently and rapidly. So this might create a window of opportunity where we can then kind of practice and strengthen and traverse the pathways that we think are antithetical to depression, and hopefully activate a protective and enduring system state through kind of allowing experience-dependent plasticity mechanisms to kick in and retain the most important pathways. So that was the crazy idea that we tested in this recently completed RCT. So we used to kind of go after these self-associations, we use different paradigms from this evaluative conditioning realm, which is something that's been studied for many decades, but mostly in the social psychology and sociology realms. But essentially, you just can take any unconditioned stimulus. Most often, this is positive stuff like positive images and words, and a conditioned stimulus. In our case, it was a self-relevant stimulus. And just repeatedly pair it with a very simple kind of Pavlovian conditioning paradigm. And you can show that this actually impacts liking and preference. And this is exactly what advertisers are doing when they're repeatedly pairing their product with smiling faces of beautiful people and trying to make you like their product. So there were some studies to suggest a hint of possible clinical potential, but little have been done in the realm of kind of full-fledged clinical trials. But we thought maybe this would be a synergistic match for what ketamine is opening up, the window that it's opening. So we drew several paradigms from this evaluative conditioning literature. So this one is our lexical version, and we gave it in both a subliminal and superliminal form to every patient. They all got both. So essentially the conditioned stimulus is the letter I standing in for oneself. And then it's just flashed briefly, then a positive word is flashed briefly, and then there's some sort of incidental task just to keep people engaged with what's happening on the computer screen. And the very nice thing about these types of interventions is that you have a really strong built-in sham version that you can make where the patients are doing the exact same thing, but just without the therapeutic content. So in this case, we flashed the letter X, and then paired it with neutral words in the sham version of training. They're still doing the exact same type of task over and over again. The other version that we also gave to every patient was a pictorial version where we actually took photos of the patient themselves and then displayed them at random, flashed them onto this 2x2 grid. They had to click as fast as they could on their own image. And then as soon as they do so, it's replaced by a photo of a smiling face from a standardized set. Whereas in the sham version, they were clicking on photos of a gender-matched stranger, and it was followed by different types of facial stimuli. Including mostly neutral stimuli. Okay, so in our RCT, patients were randomized 2-to-1, as I mentioned in describing the DWI findings. So the reason for that is that the ketamine group was further split in two. So here what you're seeing is just the effect of ketamine at 1 day after infusion. That's this larger dip here that you see at day 1. So everybody got either a single infusion of saline, which is the blue group, or a single infusion of ketamine, which is the gray and orange group. Then and so this corresponded to a 52% responder rate in the ketamine group, so very much in line with what we had found in the mega analysis as well. So The next, after that first day, they began cognitive training, which consisted of 30 minutes or so total a day for 4 days of playing this computer game and nothing else. So then we followed them for a month, initially getting our clinician rated primary outcome. And we found that the group in orange, which got the ketamine plus active cognitive training, is now being compared to those who got ketamine plus sham training in gray, or those who got saline plus active training. So it gives us a control group both for those who get the behavioral component without the drug and those that get the drug without the behavioral component. And so what we see is these very parallel lines characterized by a main effect with no interaction effect over time between the blue line, the saline group, and the ketamine plus active group over the entirety of the 30 days. And this is a moderate effect size. Whereas in the group that got ketamine with the sham training, you see what you typically expect after a single infusion of ketamine, where they're just over the ensuing weeks, they're gradually kind of dipping back up. So this is encouraging, and we are conducting a naturalistic follow-up for an entire year. So after that, patients are going out and of course seeking whatever other treatments they want. But so, this is very much still ongoing. So far out to month 3, we're still seeing, sorry about the color schemes switching up on you, but in our self-reported measure, which we're collecting during this window, we see that the green line, which is the active group, is still looking better than both of the comparator groups out to 3 months after this very short intervention that we gave. So I'm fortunate to be partnering now, as I mentioned at the onset, with the Innovation Institute at my institution, who have incredible expertise in trying to see how we can find a pathway from a research innovation to something that, in my mind, hopefully actually can get to providers and patients. And they have expertise in this, which I certainly do not possess. So they're partnering with me in seeing if we can get this all the way out there, because I've seen so many interesting ideas that kind of echo within the academic sphere and don't get out there. So the first step, the milestone that we've reached, is to file this provisional US patent on these methods and systems for neurocognitive training following a drug administration. So it'll be an interesting adventure to see where it leads from here. Another future direction is that we are now embedding this entire kind of model of intervention into a very real world setting and trying to use it to address one of the most pressing clinical needs, which is reducing suicide risk among very high risk patients. So what we're doing is recruiting inpatients who have just had a medically serious suicide attempt during their inpatient stay. During the phase of medical stabilization, they already typically have an IV in. We can very easily give them a ketamine infusion in that setting. And then when they proceed into standard psychiatric inpatient, we can meet them there with our web-based app and give them the cognitive training. And so we're testing, this is all hypotheses at this point, but we're testing whether the combination of ketamine with the active cognitive training might create an enduring impact even on suicidal behaviors or other kind of high-risk outcomes. So in a pilot, we showed just as a kind of proof of principle that those very same rapid effects on suicidal ideation that we've seen so many times in the research context in depressed outpatients can be found as well following an infusion of ketamine in this medical setting with these very heterogeneous patients who include some of the most difficult to treat patients, like those with very repetitive suicide attempts, those with active forms of suicidal ideation, and with critical comorbidities, including addictions. And our version that we're using now for this study as well, it includes all the components I showed from the previous study, but we've also tried to enhance it a bit with some new paradigms. So this one shows my daughter, Juliet, standing in as for a photo of the patient. So this would be you as a patient, and you're asked to memorize associations between your self-related images or words and stimuli that are positive, stimuli that are related to life, as shown in this growing plant as an example. And then this is more of a distractor, kind of just a filler item. And then you need to select the correct match from this kind of matrix. So it comes across as a memory type of game, but really the whole thing is rigged because every single item in this matrix is either self-related or positive in the active version. And then the sham version is just the same exact game, but with all the pairs being neutral combinations. And so since this is a very real world kind of deployment focused study, we're interested in measuring the satisfaction, acceptability, any barriers or facilitators to uptake from both the providers and the patients. And so we're encouraged that so far we're getting very, very high acceptability and satisfaction ratings from our patients, so around 80% or higher for both the ketamine infusion procedure and for the cognitive training procedures, even though they're sort of boring. Patients are giving us positive feedback. And in spite of everything else that these patients have ongoing in their life at this point following the suicide attempt. And I also am encouraged that when we split our sample according to whether the patient is from an underrepresented minority, racial or ethnic group, we can see that the acceptability high ratings and satisfaction ratings remain high, which is important to me and encouraging to me, as one goal that I have is to develop delivery models for treatments that are so portable that they could be used in a wide range of community-based settings, serving where our under-resourced communities in the highest need. This is all of the many, many shoulders of people that I'm standing on, and this is only just for the suicide attempter study. This is the team for that study alone. Here are some of my other key collaborators throughout my career that I wanted to thank, and thank you for listening.
Thanks very much, Becca. That was really fascinating. I can already see there's a few questions. So yeah, maybe we'll just take a couple. Yeah.
Are you exploring either repeating the cognitive training later in a block or continuing it, seeing the effect appears to at least dissipate a little bit?
Yeah.
Tried that yet?
Not yet. The second study in the suicide attempters, we got funding for that before I actually had the results for the first one. So it's very much the same design, but I agree that booster sessions. And so what we did, since we changed it to a web-based delivery model, we give them access to continue to use and kind of self-administer booster sessions. So I'm very curious whether any of the patients will actually do that. We send them kind of just an automated friendly reminder every so often that you have access to this. So that'll be an interesting data point in and of itself, whether patients left to their own devices kind of continue to access this. But yeah, I think it's a really crucial question. Like, this just shows us the tip of the iceberg in terms of whether we can get more bang for our buck here.
Can I ask a quick one first as well? Did the patients know they're in the sham group with the cognitive training?
Thank you. I forgot to mention, they did not. So everybody in every group was, their median was 50%. They did not know whether they got active or sham, and there were no differences between the two groups. So the blinding worked for that. It did not work, of course, for ketamine versus saline, which I expected.
Yeah, I'm going to ask a question along those lines, maybe just following up, because I guess if you're going to do this at large scale, the rationale for your intervention will become available, right? So people will know, I've got to take ketamine, and then they're going to reprogram my brain with subliminal messages that they're flashing up to me. And so I guess I was kind of interested if you've thought about just explicitly telling folk, this is the condition. We're going to show you some positive stuff about you, because like some of the stuff in the earlier stuff with training that had slightly complex effects. I think, right? If you instruct participants about the training and whether it might be important.
I'm thinking of the attention bias findings where there was a bad effect of the press that some of the findings got because patients learned about too much about the paradigm. Is that what you're kind of alluding to? Yeah.
Other stuff that I'm not sure if it was ever published, but they just randomized people to either just be told what was happening in training or not.
Yeah.
A bigger effect on their adult measure outcome, but then a smaller effect on anxiety. They did it as well. And so I guess yours is a bit, I'm not sure whether explicit knowledge of yours would be a bad thing, to be honest. It might be. But it would certainly make it easier to do repeatedly in the real world if you're going to.
Yeah, that's a really interesting suggestion.
One quick last question from Sagar. Sorry.
Well, first of all, thank you for a brilliant presentation, and especially thank you for doing work with depressed suicidal patients, which most researchers and certainly all drug companies avoid. I'm just curious with the cognitive training, since you started off with neuroimaging data about what ketamine does, is there any background data that this kind of cognitive training actually through imaging has an effect on neuroplasticity? Not
much, if any. But yeah, I do have among the mountainous trove I mentioned, we actually get imaging again just after either active or sham cognitive training, and again at day 30 at the last kind of in-person visit that we did. So we will be able to look more long-term. So far, we've just focused on the impact of the ketamine on that one measure. So I have multiple collaborators looking at the different sides of the coin, and hopefully, I really would love to have an integrated story of kind of how all these pieces fit together at the end of the day.
Oh, well, it's time for tea. So thanks again to all of our speakers. And yeah.
Thank you. Yeah.
was to say, it was always definitely the place to be if you're looking for recruit. Yeah, when does that start? Wow. Back, and then
I'd like to remind you about Fabian. Fabian is in Broad Street, fairly near where the reception was last night. And it's at Marshalls Lodging at 6:45 is the reception. And then we're going to go to the dining hall where there'll be a short talk about the anatomy of melancholy by Dr. Burton. I think that'll be a lot of fun. And if you're going to the dinner, please bring your ticket with you. And if you can't go to the dinner, please let us know. If you can't go to the dinner, let us know so that we can. And if you want to go, there may be tickets available for you. So please, again, let us know upstairs. Thank you very much.
Okay, is everybody back in? I'd like to just quickly, to keep us on time, announce the first speaker. Kevin Yang from the University of San Diego is going to talk about recreational ketamine use. Is associated with high risk for depression among adolescents, but not consistently among adults. Results from 2 US nationally represented surveys. Thank you, Kevin.
Thank you. All right, good afternoon, everyone. Thank you for the introduction. My name is Kevin Yang. I'm a fourth year and in my last year of medical school at the University of California, San Diego. First off, I want to thank Sarah and Rupert for having this conference and for having me here today. Very excited to be here. Also wanted to just acknowledge my colleagues, Dr. Benjamin Hahn, also from the UC San Diego, as well as Joseph Palomar from NYU School of Medicine. And as you can see, the title is recreational ketamine use is associated with high risk for depression among adolescents, but not consistently among adults. Acknowledgements and disclosure. So research was supported by the NIDA, the NIH, and also all authors have no conflicts of interest to disclose. So for some brief introduction, major depressive disorder is common in the United States among both adolescents and adults. In adolescents, it affects almost 1 in 5, and in adults, it affects almost 1 in 10 adults. And the rates of these are increasing in the United States as well. Additionally, major depressive disorder and suicide are highly related. Suicide is also the 2nd and 10th leading cause of death among adolescents and adults in the United States, respectively. And major depressive disorder is also highly associated with psychoactive substance use, particularly with respect to alcohol, cannabis, and opioids. So as such, it appears that those experiencing depression may be at risk for other psychoactive substance use as well. And here comes ketamine as a treatment for depression, because of all the comorbidities associated with depression and because of just the increasing prevalence, there's been a big need for innovative and effective treatments for depression. And so as you guys are all aware and why we're all at this conference, in the past decade, there's been many, many studies that have demonstrated how ketamine is efficacious in managing treatment-resistant depression, with research also demonstrating efficacy among adolescents as well. This is just a forest plot taken from Mark and Tony et al.'s paper in Journal of Affective Disorders in 2020. Just an example of how you can see from the systematic review that in comparing placebo to ketamine, it certainly does seem to favor ketamine. And subsequently, as you would expect, there's been a significant increase in clinical research, media attention, and just rising ketamine clinics targeted for the treatment of depression. And most of this, of course, is all in clinical settings under medical supervision as well. However, as you can imagine, ketamine is used outside of clinical settings and outside of medical settings as well. It is used as a recreational drug of abuse. These two figures are from Dr. Nutt's papers in Lancet in 2007 and 2010. Him and his colleagues essentially just kind of use their own assessments to try and create this graph of how relative to other drugs, what is the association in terms of severity of dependence and also with physical harm as well. And you can see highlighted in the blue for ketamine, you can see it's right about in the middle in terms of the severity of the dependence, as well as the physical harm associated with it on the left graph. On the right, you can also see in terms of just the overall harm score that they created. It's right there about in the middle, maybe in the lower middle end of that as well. So, just the big takeaway from this is, while ketamine is not necessarily, a severe drug in terms of dependence and physical harm, it certainly can have dependence and physical harm and abuse associated with it. And that's kind of what brought us to led us to this study, is that we wanted to see the extent to which ketamine use relative to other drugs, what was that extent of people reporting depression? And so we did this by using 2 national representative studies. These are both in the United States. The first column on the left is Monitoring the Future survey. So this is an annual survey given to high school students. We specifically looked at high school seniors. So these are usually around 17, 18 years old. And we used the years 2016 to 2019 with an N of over 15,000. We also did another survey looking at the National Survey on Drug Use and Health. Specifically, we looked at adults 18 years and older. And these were between the years of 2015 and 2020 with an N of over 240,000. In terms of measures for substances, we of course looked at past year use of ketamine, and then and additionally as other drugs as well, which will be shown in the next graph. For depression, for the Monitoring the Future survey, this questionnaire, there were 4 questions that were derived from the Bentley Medical and Psychological Functioning Inventory. This questionnaire has been shown to have high reliability and high validity, and has been used in a multitude of other surveys as well. And what we did is we defined it as having a high level of depression if they scored in the top 25 percentile of the average reported symptoms. And then on the other hand, with the National Survey on Drug Use and Health for depression, that was used based off the DSM-4 criteria for having a past year major depressive episode. For statistical analyses for both of these, we did bivariable comparisons using Rouse, Scott, chi-squared. Then we did generalized linear models using Poisson and log-link, which gave us adjusted prevalence ratios. Additionally, for the Monitoring the Future survey, we also, because of that survey did ask how often and how many times they've used it in the last year, we also examined the frequency of use of each drug in relation to depression. And then at the very end, you can see just the list of other confounding variables that we did adjust for in our analyses. So we'll start off with the adolescents. First off, just in terms of just the past year recreational ketamine use, we did find that there's an N of 149, which is weighted at 0.9% of that population. On biovariable tests, we found that those reporting past year use of each drug, other than alcohol, they were more likely to report having a high level of depressive symptoms with P's less than 0.01. And this figure on the right is the multivariable models that we created. And as you can see at the very top, ketamine was associated with the highest risk for reporting a high level of depression with an APR of 1.55. Then it was followed by use of cannabis, and then followed by non-medical use of tranquilizers and amphetamine. And then interestingly, you can see at the very bottom, alcohol was actually associated with a decreased risk for reporting a high level of depression. And then of course, everything else in between were not statistically significant. And then because we did find that ketamine was associated with reporting a high risk of depression, we also looked at the frequency of past year use in relation to depression. So starting with ketamine was 0 as the reference, we found that if they reported using ketamine 1 to 2 times, the APR was 1.37. If they used ketamine between 3 and 9 times, the APR is 1.65. If they reported using ketamine greater than or equal to 10 times, the APR is 1.70. So in other words, there was a dose-response relationship with ketamine to the point where if they reported using greater than or equal to 10 times, there was a 70% increased chance of reporting a high level of depression. So what about for adults? So in the adult survey, the past year ketamine use, the N was 484, which is weighted at 0.2% of that population, of the aggregate population. On bivariable tests, again, we found that those reporting past year use of each drug other than, those reporting past year use of every drug were more likely to report a past year major depressive episode. And then here you can see the graph for the adult survey in terms of the multivariable models. And you can see ketamine is actually there in the middle. And so what happened, we found that, although ketamine was associated with an increased risk for experiencing depression in a bivariable manner, 0.6% versus 0.1% with P of less than 0.001, we found that this use was actually no longer a risk factor in the multivariable model. We ended up getting an APR of 1.23 with a 95% confidence interval that did include 1. And then you can see, however, that past year use of marijuana, misuse of prescription tranquilizers, sedatives, misuse of prescription opioids, methamphetamine, and LSD were all associated with reporting a past year major depressive episode. Interestingly, you can see at the very bottom, you see that past year use of ecstasy/MDMA was actually associated with the decreased risk for reporting a past year major depressive episode. So in summary, we found that past year recreational ketamine use is a risk factor for reporting depression among adolescents in a dose response-like manner, but not consistently among adults in the United States. And then just to briefly go over some limitations and then followed by a brief discussion. Since this is a survey, it's certainly subject to social desirability and recall bias. It also doesn't differentiate between those using for medical versus recreational purposes. Additionally, individuals living in institutionalized settings such as prisons and jails were not represented. And then lastly, because it's a cross-sectional survey, we are unable to determine the association between substance use and depression. And this last point was something that I just wanted to talk about a little bit further, just in terms of the question of the chicken or the egg, right? Is it that ketamine use causes depression, or is it that those experiencing depression are more likely to use ketamine? And there is evidence for both sides. There's lots of reviews and longitudinal studies that have shown that ketamine does have abuse potential and long-term effects. Long-term use has been associated and been shown to cause cognitive impairments, depression, psychosis, as well as bladder damage and cystitis, which many people have talked about today and yesterday as well. Additionally, there's also research showing that people are using it for self-treatment as well. Probably one of the notable things is, it creates this unique, dissociative effect, kind of this out-of-body experience where you can, escape. And certainly if you take more than heavier doses, then you can get into the so-called K-hole as well, that many people might want to use if they were to escape from depression, for example. Additionally, just in the context of all the increasing research and the media attention and rising ketamine clinics, it's certainly possible that it may be affecting people's perceptions of the risk of using ketamine, and it might be influencing subsets of people to use. And that's indeed what some researchers have found. This one on the left by Dr. Palomar, this was done in the last year. What they did was they did a survey of over 200 people going to nightclubs in New York City and asked them about their past year use of MDMA and ketamine. And then they also asked them, whether or not they've seen the perceived medical benefits in the news and whether or not it would affect their willingness to use it in the future. They found that, of that sample of over 200 people, 10% had endorsed saying that, because of the medical benefits of ketamine, they would be more likely to use ketamine in the future. And then additionally, of those who had used ketamine in the past, 50% of them said that they were more likely to use ketamine because it's been shown in the news to be more helpful and more beneficial. On the right side is something somewhat similar. These authors just looked at the print and news media and how they framed ketamine. They found that in the beginning of the 2000s, ketamine was in the news was more looked at in a negative connotation. The abuse associated with it, the negative effects, and then once you get to the late 2015s or later on, they found that there was significant change in perceptions, talking about its use to treat depression, how it can be very effective, and kind of just this treat-all kind of thing. And then certainly there could also be indirect associations that might not be able to know about. For example, the typical demographics of those who use ketamine usually are adolescents and young adults. These drugs are often used in clubs and raves. And people who use ketamine often are polydrug users. So it's possible that the associations might be, for example, maybe it might be people who are likely to have access to these drugs or access to these venues and raves, as opposed to just this direct relationship between them. So in conclusion, to our knowledge, this is the first national representative study that evaluates the extent to which ketamine is used recreationally relative to other common drugs among adolescents and adults reporting depressive symptoms in the United States. Additionally, although recent trials suggest that ketamine administration in clinical settings is efficacious in treating treatment-resistant depression, our study demonstrates that past year recreational ketamine use is a risk factor for reporting depression, at least among adolescents. And lastly, understanding why ketamine use is a risk factor for reporting depression is imperative to minimize harms and address the needs of this vulnerable population. And those are my references.
Thanks, Kevin. That was great. There is a few minutes for questions. Yes.
Sanne Smit from Groningen, the Netherlands. Thanks for your presentation. And these findings are actually in line with the current survey from the Netherlands, or a recent survey from the Netherlands. And one of the things that people also said that they thought ketamine must be safe because we treat it as, or we use it as a medicine. Is that something you recognize? And if so, do you think we should, as doctors or researchers, should do something with that?
Yeah, I mean, that's a really good question. One thing that I would love to learn more about, and I've looked for qualitative studies and whatnot, is just, how was all this news media of ketamine, and not just ketamine, but recently with psychedelics especially, how is that affecting whether or not people want to use it in the future, or whether their perceptions of risk. And so that's something that certainly we can continue doing with national representative studies to look at these changes in perceptions of risk and harm. But yeah, I mean, it's a great question, and I'm not really sure what the answer to that would be and how we can frame these things, but it does seem like, we would expect, given all this news media, that the prevalence of use might increase because of it.
Other questions? So while if anybody's thinking of a question, I have one for you, Kevin. So I was interested in the one for the adults, that heroin actually wasn't associated with depression. So that makes me question is there an explanation for that?
No, we didn't look more specifically into that one. There's certainly many things that could be going on, maybe, poly drug use or just maybe looking at specific demographics, because we didn't stratify by the demographics. So that's certainly something that, we could do in the future, but it's not something we looked at.
And then I'll add a comment. When you are talking to the media, they have an agenda already. So you have to be really careful. You basically have an 8-second soundbite. So it's really you have to be careful how you say that. But I've had media people call me. I've had the most recent was, we've done a lot of positive studies on ketamine. We want to do a negative one. So, I mean, this is the type of stuff you do get from it, but it is important. I think the recent US, I know Nora Volkow was just also mentioning that looking from the CDC database, there is an increased use of ketamine and of most of the psychedelics too over the past 2 years too. So it clearly is. Any other questions? Yes.
Hello, thank you. Really interesting presentation. I wondered if you had any thoughts about why the relationship between ketamine and depression is different among adolescents and adults. So why?
Yeah, that's a really good question also. And the best answer I can come up with is, usually, like I mentioned earlier, ketamine is used recreationally in club contexts and raves and whatnot, and festivals, things like that. In the US, you have to be 21 and older in order to be at these events. So it's possible that, at least among adults who are using it, they might not necessarily be depressed. They're using it more for recreational, for fun purposes. Whereas if you're, 15, 16 years old and adolescent in the US, the reasons for using it probably are very different than going to a club. It might be using it to actually self-medicate your depression, for example, or causing it. So that's the only thing that I could think of, but I've tried looking online as well, or looking through studies, and there's not really much there.
Thank you, Kevin. Thank you.
Thank you.
Perfect. I'm sorry, I think to stay on time, I think. Do you have one more and then?
What about the UK? I mean, you say the Netherlands is on par, same sort of, numbers. What about the UK? Does anybody know how we're doing? Because we drink at a very young age, and the adolescents do. So, I mean, we have we're all. You can't drink until you're 21. So, I mean, I think they might be quite considerably different.
I think we can say, I mean, Celia is the expert on this, but
Yeah, where's?
Use is higher in the UK than in the US. For
can you
sure.
speak up? Yeah.
The incidence is higher in the UK than the US of ketamine use as well. I think we probably use more drugs and drink more alcohol, as you said, than people in the US, but particularly among adolescents. Yeah.
Thank you.
Right,
Thank you, Kevin.
Mm-hmm.
Thanks. So next, I'd like to introduce Rodrigo Machado Rivera from the University of Texas, USA. He's going to talk about kynurenine pathway and biomarkers of response. Hey, Rodrigo. Sorry.
Hello, can you hear me? Yeah. Okay. Thanks, Rupert and Sarah, for the invitation, and thanks, Carlos, for giving me some slides for this presentation. We worked together for several years working on blood biomarkers of ketamine response. like a decade ago, and like to go over in this presentation some findings that you had at NIMH and some recent updates in this area. Basically, ketamine is a complex drug, that targets several neurotransmitter systems, intracellular signaling cascades, mitochondrial function, oxidative stress. And by being so complex, it could be called like a multimodal approach for depression. And depression that ketamine tries to target is a very complex disease that it has atypical features, melancholic features, anxiety, comorbid symptoms. And in this case, we are matching a very complex drug that has several mechanisms of actions with several very complex disease. So the task to find biomarkers for this condition is very complicated. So we are trying to approach in a way that we can identify biomarkers that are related to clinical response in a sub-specific group of patients. Basically, in this case, we have to identify blood biomarkers and other biomarkers that could be related to response and remission, like predictors of response, baseline levels of biomarkers that cross-sectionally you have a clinical outcome later on, and surrogate outcomes, which is more sophisticated by having the biomarker measure more than once. So the clinical improvement would match with the changes in the biomarker. So this is my disclosure. I have a couple of clinical trials in depression and suicidal ideation with ketamine, and but no current study on biomarkers. So in terms of biological systems and biomarkers of response to ketamine, Carlos presented yesterday a wide range of findings related to improvement of depression associated with changes in connectivity, epigenetics, neurochemical, neuroplastic. So depression in this case has a wide range of findings related to you see the AMPA, throughput, and MDA. In this case, that was the first biological mechanism proposed that was presented here already, showing that by blocking the AMPA activation, you would abolish the rapid antidepressant effects of ketamine. And this would be related to the early effects of ketamine, and the sustained effects would be activation of neurotrophic effects through CREB, BDNF, and BCL2. That was early 2008, like several years ago. More recently, we had more findings supporting increased AMPA throughput and activation of AMPA receptors, mTOR, EF2, and BDNF. How this could be translated into like clinical new options for depression. mTOR is complicated because if you upregulate mTOR activity, you put the body at risk for cell proliferation in organs other than the brain. So mTOR is a key target in cancer research. So as a mechanistic approach is interesting, but when we think as mTOR as a potential therapeutic approach, is more limiting. The same for GSK. GSK inhibition has been associated with the effects of ketamine, but if you consider GSK inhibitors for depression, you are going to also find several side effects that are not expected in different organs. So also suppression of glutamate input to GABAergic neurons and synaptogenesis and dendritic remodeling. These are basically the main models, mostly done through preclinical studies, and which we have to think about how to translate this into our blood biomarkers in patients. So some of them we are not able to obtain, but most of them we were collecting time by time some biomarkers from preclinical studies and testing our patients for NIMH. So basically, in terms of the predictors, BMI was the first that came out. So obesity would be a factor to improve response to ketamine. But we have this question, you give more ketamine for those obese patients because it's per kilo. So the more kilos, the more ketamine you're gonna give to the patients. And family history of alcohol use disorder was another clinical predictor. Then another evaluation was the predictors. Once you improve depression after 1 day, what are the symptoms that were related to long-term improvement? So all the findings that we present here are based on a single IV dose and the improvement after 24 hours, predicting improvement after 14 days. The remission and response after 14 days was low, like 20 to 30%. So it's important to identify specific symptoms that would be related to improvement later on. Before starting on the blood biomarkers, these are also findings from the NIMH group at that time related to sleep ratio, MRS, low GLX glutamate ratio. Giacomo Salvadore did other paper on increased treatment ACC activity. And we confirmed that BMI was a strong predictor as well as family history. So moving along with the biomarkers, the blood biomarkers, we collect blood, plasma, serum, RNA, and we had a wide range of markers that we evaluated. This was one of the kynurenine pathway and antidepressant response to ketamine. Basically, we evaluate at baseline and after day 1 and day 3. So the main findings is that like the enzyme indolamide was lower after ketamine, which means that tryptophan would go to serotonin and melatonin, to the other side of this cascade that I'll show next. And the kynurenine basically would increase, you see like B, that would also activate the kynurenic acid. And this is the step related to neuroprotection. When you think about neurotoxicity, you would consider the quinolinic acid, which is the last one, D, that did not change over time. So it seems that ketamine activates this pathway, but related to astrocyte effects to block an MDA receptor. So it could be a kind of booster in terms of ketamine effects by also blocking an MDA receptor. This is basically the mechanism by which kynurenine would increase kynurenic acid in the astrocyte and activate, block an MDA and alpha-7 nicotinic receptor, which was also related to antidepressant effects of ketamine in early studies, which would also block quinolinic acid. So basically, this is an important finding that also by the other side could block oxidative stress, activate, impair mitochondrial function, and limit the production of quinolinic acid. So since we observed that the BMI was a strong predictor of ketamine antidepressant response, we perform evaluation of adipokines. Adipokines are basically regulate inflammation, neuroplasticity, insulin sensitivity, bone metabolism, and sympathetic outflow. So we evaluated adipokines at baseline to 30 minutes, day 1. Some of them we did at day 3 after the IV infusion in 80 patients. So the 3 adipokines we evaluate were adiponectin, resistin, and leptin. Adiponectin is kind of good guy, improves all the parameters. Resistin is the bad guy, and leptin is like 50-50. You see next the effects of each one. Basically, you see here adiponectin can improve insulin resistance, can decrease the sympathetic increase output, and could have anti-inflammatory effects. It could improve plasticity. Leptin would improve insulin resistance, and could decrease sympathetic tone, but wouldn't have positive effects in inflammation and plasticity. So leptin is the insulin, the enzyme that you see that has a key role in obesity. You remember that those animals, the rats, very obese, was related to leptin. Resistin would be like deleterious in several aspects related to insulin resistance, sympathetic flow, and would impair plasticity. So we're expecting to lower resistin after ketamine and induce positive effects in plasticity. Remembering that these are all blood markers, that some of them have the criticism, what would be the correlation with the CNS? Some of them we have evidence, but not for all. Basically, we didn't see any change in adiponectin levels, but baseline adiponectin predicted the rapid antidepressant response of ketamine. So lower baseline adiponectin associated with higher superior antidepressant effect. Leptin increase over time at day 1, but there is no association between change in depression scores as well. And resistin lower after ketamine at day 1. And surprisingly, so far, no one can explain, and we didn't find any reasonable hypothesis to support why resistin lower in bipolar patients, but not MDD, which is very strong, like you see from baseline to day 1 in bipolars. There is a significant increase, but we don't have any clear explanation for this findings. Other peripheral marker we evaluate was SHANK3. Basically, SHANK3 regulates synapses and can activate an NMDA receptor. So we evaluate blood SHANK3, and SHANK in preclinical models have been associated with manic-like symptoms as well. So baseline SHANK was a strong predictor of antidepressant response to ketamine at day 1 and day 3. Higher baseline was associated with greater improvement of ketamine. So the NMDA receptor would be more active by having higher SHANK levels and would give more room for ketamine to induce antidepressant effect. But there is no change over time in SHANK3 levels, just the baseline levels predicting response later on. And this finding, the baseline peripheral SHANK3 was also associated with increased glucose metabolism in the hippocampus and amygdala post-ketamine infusion. Back to the bone, basically ketamine seems to be a good medication to treat osteoporosis in some cases, because this was suggested by Phil Gold. Phil Gold was our mentor at NIMH. He was in charge of the all metabolic panels and studies. And he suggests us to do these biomarkers, which are bone markers, RANK-L, and OPG. They are related to bone formation. And the findings we have is that all the good guys in terms of improved bone density were increased after ketamine, but there is no association between these markers and improvement of depression. So that's like a kind of incidental finding in terms of potential relevance in other conditions other than depression in this case. Dysaurin was also a response marker to ketamine. There is an association between baseline dysaurin and L-serine and antidepressant response to ketamine, with lower levels predicting a better response. So basically, dysaurin and L-serine are co-agonists of the NMDA receptor. So if you have lower levels, you have less active NMDA receptor. So that would help ketamine to make effect faster and more robustly. But did not change over time. You see here, there is a difference in the dysaurin levels compared to comparing responders and non-responders, with responders having lower level, but the levels do not change over time. So ketamine did not directly affect, but it seems that the levels can account for the clinical response in depression. This was another study we did at GWAS. We didn't have too much power in this study, kind of small sample size for GWAS. But the top candidate in this study was MCF2L2, that is basically focused on, has main effects on plasticity, cytoskeleton organization, and cell proliferation. So we talk a lot about plasticity. Plasticity is a very generic term, and when we discuss association with depression, we can find a wide range of potential concepts of plasticity, but in this case is related to cell proliferation. This is an overview of the findings in terms of improvement of depression at day 1, predicted by baseline biomarkers of response. So we have the biomarker, the baseline levels of each biomarker, and how were they correlated with improvement at day 1. So L-serine and D-serine seem to be good candidates, higher baseline related to better response, and SHANK3 the opposite, lower baseline related to better response. And we had some other candidates, ACTH, we're not able to explain well or even like explore more this pathway, the stress pathway. But ACTH, higher baseline ACTH seems to be related to better response to ketamine, which supports the HPA axis modulation of ketamine. When separate across different dimensions like the glutamate, inflammation, metabolic, and plasticity, we observe similar findings. Again, BDNF came out significant. Our first study with BDNF, we didn't see any change over time, but subsequent analysis, we observed increase in BDNF over time in association with clinical response. When we put together clinical and biological predictors of ketamine effects, L-serine and D-serine are the top ones, and then SHANK3. A little higher than BMI and family history of alcohol. Then you have adiponectin and other findings, but basically we have like Pearson 0.5 for L-serine at baseline. That could be help to stratify samples in the future. Basically, here we show different biomarkers related to change over time. It's a little complex, this figure, but you see like in red ACTH, that is like biomarker that has correlation with depressive change over time. And BDNF related to change in depression and change in the marker. So we observed that the same way patient improved depression, but BDNF went up. And that matches with recent literature. This is a meta-analysis comparing baseline levels of blood-based biomarkers in responders versus non-responders to ketamine. This is in present molecular psychiatry, and you can see that when you compare only baseline, you don't see any difference for any biomarker, and we select basically at studies that had at least 3 studies for specific biomarker. But when we observe like changes in responders and non-responders post-ketamine, we see a significant effect for BDNF for responders. So you don't see the same trend for non-responders. So it seems that after giving ketamine, you see an increase in BDNF levels related to clinical response in depression. Inflammatory markers in this meta-analysis did not show any difference by comparing to IL-6, TNF-alpha, IL-10, and IL-8. So conclusions, basically, BDNF seems to be a good candidate. Inflammatory markers at baseline predicting antidepressant response. Adipokines, plasticity, and MDA, and other targets. There is like methodology issues in terms of analyzing each biomarker. For example, BDNF, if you go back to the results, you see the levels at baseline, the mean, very heterogeneous. So each researcher uses a different kit from a different company with a different sensitivity, and you don't have like a clear result. So if you have BDNF between 100 and 1,000, this is within the normal range. So we are looking for biomarkers, blood biomarkers, that would be great, but we still didn't get to the point to have like a homogeneous way to analyze all the biomarkers and come up with some result that would allow us that's normal, that's abnormal, and all the researchers across the country or anyone doing ketamine related research could use the same method exactly to come up with similar results. Thank you.
Any questions? Yes.
So beautiful talk. Given your data clinically, should we, and the cost of ketamine infusions, should we be getting L-serine, D-serine?
Very good question. This is like a preliminary data. I think that would deserve like a higher sample size, more patients. Seems promising, but at this point, nobody has replicated this, which would be timely. I've seen a couple of preclinical studies exploring a little bit these markers, but in practical terms, at this point, I would not recommend.
Another question?
I have one.
Yes, sure, Sarah.
Thank you. I was wondering, when you look at responder and responder and biomarkers related to that, would be after a single infusion?
Yes, all the data I present here is after a single infusion. We didn't do at NIMH basically repeated infusions, at least when I left like 5 years ago. I'm not sure Carlos is doing now, but all 0.5 milligrams per kilo single infusion and follow up for 2 weeks, no more than 2 weeks.
We have.
You have repeated now? Okay.
Rodrigo, I have one question. I mean, you sort of broke it down by function. Did you break it down by cell type at all? Like D-serine is largely generated in the astroglia. You mentioned that as a thing. Have you looked at other? I saw S100 beta, it didn't look too big. How about like GFAP or anything?
We did several GFAP and several other neurotrophic factors. None came out significant. And we did all in plasma samples. We didn't collect like, we collect lymphocytes. No, we collect PAX gene like RNA, but no lymphocytes, no cells.
Okay, thank you. Thanks. Okay. So, and for our last talk, I'd like to introduce both Jeff Becker from Bexon Biomedicals and Jason Wallach from the University of Sciences, Philadelphia, I believe. And they're going to discuss progress towards subcutaneous ketamine and psychedelic formulations for pairing with an automated wearable delivery system for use in pain management and mental health indications. That's quite a title, Jeff. All right. Thanks.
Sorry about the...
Okay, and then moving slides forward. Is there a time? Good. Thank you, everybody. I want to echo Dr. Price's her thoughts about just feeling grateful to be here. This talk is a little bit different. I'm actually really humbled by the level of the science and just the community and how much we're trying to solve these problems and really discover answers for people. I've been working for about 4 or 5 years to develop a new approach to delivering ketamine, specifically subcutaneous, and have a chance to show you a little bit about where we're at this point. We have a very nimble team. We are working, moving quickly. We've got Greg, who's here at the conference. He has a long history of drug development. Me, I have a lot of clinical experience with ketamine. Sheldon Moberg, who has expert history in developing pumps. He actually developed the Paradigm pump for Medtronic way back. Rosemary Gonzalez, Kevin Brune, and of course, Jason Wallach, who's a legend in NMDA receptor chemistry. And we put our heads together and decided that we were going to look at pain as our first approach, partly because it was a market that was not as saturated, but also because as a practitioner, I have about probably somewhere between 1,500 to 2,000 treatments that I've sat specifically in, usually about 2 hours. I've just really seen what ketamine can do for pain, both in the session and after the session when I follow up with patients. We also have a massive crisis in the United States. Currently, the opioid crisis is basically killing as many people as World War II did in the American circle, actually for the Brits as well. So we have a massively lethal problem that we need to solve. We're looking at post-operative pain as we're starting because it really looks like if you can stop acute pain from turning into chronic pain, which ketamine has substantial potential to do that, we can stop some of the opioid development of crisis, the kind of appetite for opioids that is so serious in the United States. There's some estimates that 160,000 Americans get addicted to opiates every year just from standard of care pain management and post-operative care. So when we looked at this, we realized that the subcutaneous delivery would be best in class if we could hack this. You can get both bolus and steady state through a basal rate if you want to. You can only do that with IV right now. You could do in clinic or in supervised settings, high bioavailability, which means you have low metabolite load, essentially procedural burden reduced as well, which is very important for psychiatry because psychiatrists are not proceduralists. It's one of the reasons why IV clinics are mostly run by internists, ER doctors, and anesthesiologists. So when we looked at it, though, the problem was ketamine is kind of like salty orange juice. High osmolality, low pH, and you can imagine why it burns the tissue, subcutaneous tissue. Generally, it's some of the only tissue we really don't deliver ketamine to that much. So you can, but people get kind of a hot nodule, sterile abscess afterward. You can do it here and there, but it's not really a commercial product generally. So we set ourselves, got together and spent about 1.5 years figuring out how to change the osmolality and the pH of ketamine and yet still maintain potency in order to be able to put enough ketamine in a wearable device. You can't have something that weighs too much and is pulling onto the tissue. So we needed to get what we needed for multiple days, potentially pain management or whatever we're looking for in a 3 ml cartridge. So I'm going to pass to Jason right now. Oh, I'm sorry, one quick thing. In the process of doing this, we've actually found that the formulation technology is highly modular. So we're now applying it to other molecules. And these are our in-house commitments that we're developing. We're also looking at, we'll show you a number of different molecules that we've created formulations that could fit in this or pen injectors that we are looking at either bringing in-house or possible license opportunities.
Cool, thank you. Sure. Okay, so I have another talk tomorrow, which I'll do my disclosures for, so I'm not trying to hide that, just FYI. Quick plug, this was a recent publication we did on this technology in pharmaceutics. So if you're interested in more of this after this talk, please feel free to check it out. The title, by the way, was 3 birds, 1 stone, kind of an idiom on 2 birds, 1 stone. Apparently the birds did not like it because on my walk over today, I kid you not, a bird shit on me. So I guess that was an interesting experience. I prefer finding pennies for luck, but I guess it is good luck. So, but you know, our kind of idea was like 1 + 1 = 3, right? How can we adjust and improve upon ketamine so that we can deliver it to subcutaneous tissue. So Jeff kind of showed you the core of the molecule. Oh gosh. Okay. Sorry. Is there a laser on this? No.
Yes, if you point it, but then wait your
Great. Okay, cool. So the idea here was we were able to find a formulation in which we could do three things relative to ketamine hydrochloride without compromising on potency, which was really important to us because the dose has to fit in a small pump or a pen. And those three things were raise the pH, make it isoosmotic, and make sure it was buffered. And this is important because with ketamine, as Jeff said, it's like salty orange juice. It's slightly acidic, it's hypertonic, and it's certainly not buffered. Right? And so if you want an effective subcutaneous formulation, you have to achieve these things. And so what we did, and I'm going to tell you how we got there, is create this compound here, which is essentially a cyclodextrin-based ketamine salt that's completely novel. And there's kind of two interesting things going on here. So first of all, cyclodextrins, I don't know if you know, are very fascinating molecules. They're able to complex things that are poorly soluble. So in the center there is a ketamine molecule that's unionized. It's free-base ketamine. That's normally not soluble in water. However, when it complexes to the cyclodextrin, which is this ring of sugars, it's able to be solubilized. The other thing we did was exploit these sulfonate anion groups on the cyclodextrin to basically form a salt with ketamine. And just real quick, that's the formulation here. Clear, transparent solution, looks like water, and then the solid form of the molecule. Okay, so we kind of, a little bit on the history. So how we came about this was we were discussing how can we improve the patient experience, right? Because of these injection site reactions. The first thing we decided to tackle was pH. It seemed like the most straightforward, easy option. And so that's how we sort of came up with Captisol. The idea being, you know, if you take ketamine HCl and add base to it to raise the pH, what'll happen is you get it a little bit to about 5.5 and then it just crashes out. Okay. And so what we did was put the cyclodextrin in to complex that ketamine free base that formed to keep it in solution. So that worked very well. You can see we were able to get the pH up to 5.5 to 6 pretty stably. And so that's an achievement over ketamine, which we purchased a bunch of formulations sold on the market, which have a pH of about 3.8 to 4. pH is a log scale, so it's between 10 and 100-fold less acidic, this formulation. But there was a problem, and that was, although we achieved a higher pH, the osmolality went up quite a bit. In fact, it was higher even than ketamine hydrochloride. So you can see here, we have concentration of ketamine on the x-axis and osmolality on the y-axis, green being our initial ketamine Captisol formulation. The osmolality at 100 mg per mil is almost 1,400 or 1,500, whereas ketamine HCl is 600. And the question was, why was it so hyperosmotic? And the reason was the Captisol molecule we were using had sodium cations to neutralize these sulfonate anions. And so in looking at it, we realized, well, you know, we're putting ketamine HCl in. Ketamine is a cation, chloride is an anion, and we're putting Captisol in, right? Captisol is an anion and it has sodium cations. We don't need the sodium chloride. We can remove that essentially. And the really neat thing about that is when you think about osmotic load, you have, say, 7 ketamine molecules, and then you need 7 chlorines to balance that. So 7 plus 7 is 14. But when we make this salt form, we have 7 ketamine molecules, but only 1 Captisol. So 7 plus 1 is 8. So if you think of the osmotic load there, it's 8 versus 14. In fact, the osmolality of this formulation, as you'll see, it has the same osmolality almost of ketamine freebase, as if we could magically just put ketamine freebase in solution and have no salt present whatsoever. So that was really cool and had never been done before. It's, as far as we're aware, the first 7-valent salt of any drug, at least that we've been able to find. And you can see at every single concentration of ketamine, the osmolality of this salt form we call KetCap is about half of ketamine hydrochloride. And so we ended up choosing 70 mg per mil because it was still like a reasonable concentration of ketamine that we could effectively deliver the dosage we wanted to with. But the nice thing is it's isotonic and isoosmotic, meaning it matches the osmolality of tissues, okay, extracellular fluid and intracellular fluid. And you can see here our formulation has the same osmolality as 0.9% saline, which is the gold standard of isotonic solutions. That's why it's so widely used. You can see just real quick, other sort of formulations that could be used to solubilize the ketamine have very high osmotic loads. Propylene glycol, for example, was almost 2,000. So that's just a non-starter for tissue tolerability. The other sort of, so I've told you now how we raised the pH, we adjusted the osmolality. The kind of last thing that's really unique and interesting about this formulation is its buffering capacity. It's important to buffer, drug formulation, especially solutions. The reason is if there's any change in pH, the formulation might not be stable. It might crash out. If you add base to your solution, it's going to crash out, the ketamine. And if there is acid added, the pH will decrease, and that destroys the whole purpose of us raising the pH in the first place. And so these experiments we did were just to show the buffering capacity of this molecule. And you can see with ketamine hydrochloride, we bring it up to pH 5.5 plus or minus 0.01, and we add little bits of sodium hydroxide base, right? And ketamine hydrochloride can tolerate about 5 microliters of this solution of base before it just crashes out of solution. And the BB106 formulation can contain double, or can tolerate double that, actually about 10 microliters of base added to the formulation before it crashed out. And this property comes from, again, those this cyclodextrin core here, right? In our formulation, a substantial portion of these don't contain the ketamine. And when we form unionized ketamine by adding base, it snatches it up and pulls it out of the solution and hides it from the solution pH. At the same time, a lot of them do contain an unionized ketamine, and that's what allows us to buffer against added acid. So same thing here. These are the different formulations. So ketamine HCl in red, KetCap formulation in blue. You can see added acid on the x-axis and pH on the y. So as you add acid to ketamine HCl, it just rapidly drops. As you would expect, there's no buffering capacity at all. Whereas with the KetCap formulation, it's able to tolerate a fair bit of acid before it begins to drop. And that's from that unionized ketamine being able to neutralize any added acid. It just comes off the cyclodextrin, neutralizes it, and then that's it. And so we realized very quickly that this sort of formulation strategy shouldn't work for just ketamine. Any small molecule that contains a basic nitrogen should work with this. And I'll present one more slide later on showing you a number of other molecules we've shown that this will work with. Here's just another example, methyl 3-MMC. It's a novel cathinone compound that we made in my lab as just sort of a test case compound. And you can see the osmolality again for the red MMC formulation here with Captazole has half the osmolality of any given HCl concentration.
So we got the formulation done, and that actually basically justified that we start spending on device development. And device development is a real thing. I mean, I honestly probably wouldn't be here if I knew how difficult it is. But we got started, and we are basically the idea here is that this is essentially a modular unit. You can develop a pump from scratch for a specific indication, or you can start from scratch thinking of it as a modular or a generic unit that can get repurposed for different circumstances. It's not a huge difference, but it's a little bit extra work at the beginning, and we started with that as our idea. And the generalities here are that we have one of the largest organs in our body, the largest organ in our body, that we generally don't deliver drugs through. And we don't deliver drugs in a way outside of IV that controls kinetics. The potential of actually hacking the sub-Q delivery system is enormous, and especially if you have a modular formulation protocol. So we got started. We're actually looking as well at pen injectors. Pen injectors have a particular potential use that's, I think, is interesting to me, which is microdosing, control over frequency and amplitude. If you think about dosing control, having lockouts of patients. So if you're using, let's say, LSD and microdosing in a commercial product for age-associated memory loss or recovery from stroke or something like that, you really do not want people taking too much of that. It might be very helpful, but if they're taking too much, it's not going to be helpful, and it's going to be a serious adverse event. You do not want that as a commercial entity that's out there. So we've entered design control with the, this is an awkward acronym, on body delivery system. It's internal use only. It'll probably have a better name than that. And the pen injectors, we've been, working on IP and also just the realities of whether we're going to do that in-house. Is there commercial need for it yet? This is really, just reiterating the main points, but this kind of 1 + 1 = 5 kind of model. Our IP, what Jason was showing you, that was the basis of our first patent. We are now, basically, I want to be specific, which is that our patent is agnostic to enantiomer and agnostic to route of administration. It's actually the salt itself. So the salt itself can be applied in many different ways. We are focusing on subcutaneous administration. There's a possible backup position to IM or something like that. But sublingual, intranasal, take your pick, essentially, because it's the salt itself. We do not have any data, but there is reason to believe that a formulation like this would be more tolerable to tissues. It may even have higher bioavailability in certain circumstances in terms of cross-mucosal transit of the active API. So regarding animal preclinical, this drug is being treated by the FDA in our pre-IND meeting. They're seeing this as a new chemical, almost like a new chemical entity. Unfortunately, we have not gotten the advantages of it being kind of a generic or kind of an ANDA model. And so we've had to go back and we're doing our preclinical. We did a low dose infusion model and basically just saw inflammation in the needle track. Looked very well tolerated. That was for everybody. That was 0.42 milliliters at 70 milligrams per milliliter, or essentially 30 milligrams over 24 hours. The mini pig, when you look at the multiplier when you're doing animal studies, is about 5.1 based on surface area and BMI. So that would be kind of the equivalent of a human getting around 150 milligrams over 24 hours. We are also performing right now. We finished the study, and I actually thought I was going to have slides for everybody, but they're actually about 2 weeks away still. There have been a lot of delays in preclinical work. Really, anybody that's out there doing it, we're all dealing with it because of COVID. But essentially, we have macroscopic observational results. At least I can tell you that the dosing here for BB106, which again is racemic ketamine, was 2.8 milliliters at 70 milligrams per mil, which is 196 milligrams, which if you use the mini pig multiplier by 0.1 or 5, is approximately about it would be like a human getting about 1,000 milligrams a day, which obviously we're not going to deliver, but it's important to look at this. And Dre's scores are basically observational. And what we saw is there was some inflammation in the site, but it actually was no worse generally in the pigs with active treatment versus saline even. So very hopeful. We'll have slides soon, fingers crossed. So what it's gotten us into is because we found out that the formulation protocol was so modular, we've actually moved on to not just ketamine. We're looking at basically other categories of treatment. Psychedelics are kind of they're dear to me in terms of just what the potential for human healing. We're looking at those. We're looking at the empathogens. We're looking at the dissociatives, opioids, which we're not developing, but you can imagine how something like this in hospice might be very helpful, or a pen injector that has lockouts, especially if people have GI side effects from opioids. So we filed on that as well. And we are essentially looking internally, we're calling this Hermes, fast work and messenger of the gods, which might be a nice way to think about the psychedelics. So 5-HT2A agonists are the typical psychedelics. We've made a number of tryptamine-based psychedelics with this formulation, specifically DMT, 5-methoxy-DMT. They've gone through short-term stability. We haven't done long-term yet. We have pathogens that are working, 3-MMC. We have dissociatives like deschloroketamine. Methoxetamine is on the wish list. We haven't done that yet. We're working through naloxone. Flumazenil actually does not use this formulation technology, but it will use the platform delivery. So again, we have two platforms. So sometimes the formulation tech works, sometimes it doesn't, but it's still an appropriate platform here. And these are the kind of some of the main molecules that we're looking at. What we did is we went through the main kind of favorite psychedelics out there. There are nice psychedelics and there's kind of unfriendly and sometimes somewhat ominous psychedelics. And so we were looking at scaffolds that were representative, that we could take forward, and also had commercial interest out there, and that we're interested in potentially developing ourselves. These are some of those. I would make the point that we have an emerging industry in the psychedelic kind of conscious medicine. And one of the things that I feel like I'm not really seeing out there is a very realistic understanding of what it means to deliver this level of care, helping a patient get into the conscious space, into the kind of transcendent space, especially with psychedelics, which can have a bit of a mean quality to them, and have a lot of GI side effects. That we believe that what we're doing right now will really address the main medical economic issues in terms of timeframes and PK control, reducing side effects by sending the drug really to the brain first before the second brain, the gut, which is laden with 5-HT2A receptors. If you look at Compass's results, I mean, I think it's wonderful what they're doing, but it's a bummer. They've got almost a quarter of their patients with nausea in the room. Anybody who works with ketamine knows that it's not nice when people vomit in the room. Addressing first pass treatment inconsistency as well, which is a big issue with psychedelics. It's a big issue with MDMA. Permitting real-time dosing attunement. These drugs come on very slowly. Generally, they come on slowly when we take them orally. And so being able to attune to a patient, okay, this patient needs a little bit more, and also to be able to ease in as well sometimes. Psychedelics, sometimes it's the proper thing to just go all in, but some people do believe that easing in can be the right model. This has tamper resistance kind of built into it, tamper resistance, possible diversion control as well, based on what we put on the chip. Chip is reprogrammable. And essentially, getting rid of IV costs and procedural burden and stuff like that to make psychiatrists actually able to use these tools in their office. Again, I will say it again, psychiatrists are not proceduralists. So anybody who thinks that they're going to bring something into the office and a psychiatrist who does not have the capacity to deliver IV is going to have some surprises. So setting parameters. Think about basically here's two use cases. This is kind of like how we're thinking about this for major depression in supervised settings. But the this would be an example of DMT. DMT IV clinic is a possibility. You have retreat centers and stuff like that, but I think you can kind of capture the best of both worlds with this model and not have to have possibly one of the most intense things you'll ever go through in your entire life with an IV in your arm. So this is, I'll let Jason tell you a little bit about this. Okay, 2 minutes.
So yeah, real quick. So these are just some of the compounds we've applied this formulation to, either in my lab or with a CRO partner. I mean, I think the key thing here is, again, just the sort of scope. These were chosen to be structurally diverse from different pharmacological classes. In all cases, these formed nice, played nice osmolarities lower than the corresponding HCl salt. Interestingly, a lot of these were able to get the pH up to 7 without any issue, which was a little different than ketamine. We have some interesting insight into why that's the case, but I won't get into that with 2 minutes left. One last really thing I think super interesting. With DXM, we're only able to get 15 mgs per million of the hydrobromide salt, whereas with our formulation, we got 70 mgs in, no problem. And we did follow-up research to see how soluble the DXM captazole salt was. And in fact, it was so soluble, we couldn't even accurately measure it. So the highest we got before I was comfortable with my students pipetting it was over 300 milligrams per mil. So that's a 20-fold, greater than 20-fold increase in solubility. That's great for drugs of any parental route, but that can influence oral pharmacokinetics as well, right? So Cmax, Tmax, and oral bioavailability. So I think there's sort of formulations like, to us, the gift that keeps on giving. There's just so much interesting potential every time we turn around.
I'm just going to run through the last slide so that you have them on the, people can look at this. We're running through the American Pharmacopoeia. We're doing a screening of all the molecules that are out there that have potential to be repurposed in this way. We think small molecules are next in terms of the shift from IV to sub-Q that we've seen in the biologics market. We're preparing for it. So thank you.
Thank you, Jeff. Thanks, Steph, and thanks, Jason, for one of the most rapid basic pharmacology lectures I've had that I actually understood. Thank you. Any quick questions? We have time for, yes.
Kelly from Perception. Really nice talk, very clever chemistry. Just a quick question. In the case of racemic ketamine, the are going to have different binding constants to the chiral cyclodextrin, right? Have you seen this, and does it affect your ability to scale this up consistently?
And that's a great question. We made both enantiomers without any issue. We're currently calculating the binding affinity of both. So far, racemic and S-ketamine have identical binding affinities, actually. So it's very likely R will as well. Actually, I was in the process of resolving it before I left here for the conference. It needed a couple extra crystallizations, but yeah, I think so. Yep.
So this unit it'll be a 6 millimeter 29 gauge, very similar to it's the insulin automated delivery. Little sting, yeah.
And do you see a feature in patches?
I'm sorry, can you just a little bit louder so people can hear it?
This looks like it might be a.
Yeah, patches are interesting. We spent a lot of time looking at patch pharmacology, and it's difficult because you really have to choose your dosing ahead of time. You go all in on certain models. As you can do certain things. You can change the size of the patch and things like that, but you get kind of caught up in a certain path before you've even really figured out what works. What we like about this is it's programmable. You can change the chip, you can change the profile. It can deliver in 3 minutes or it can deliver in 3 days. It has bolus delivery, it has a bolus button, it runs, you can do basal rate, you can do anything you want. It's a pocket IV.
Well, how you have to say some concluding remarks. How often do you change?
If this were post-operative pain, you would put one pod on and it would basically run its rate over 24 hours. You could choose to stop it. You can bolus with small hits, but not enough to get too far in. And then at 24 hours, you would have another pod and you put it on another site or not. So, yeah.
All right, any last minute, because we're at 5 right now. There's a burning, last one.
Very quickly, I can see the benefit of 24-hour continuous infusion for, say, microdosing with psilocybin, the MDMA, not that there's any evidence for that. But when you're using it as an adjunct to psychotherapy, then do you really need to improve on a single one-off oral bolus? It doesn't require continuous infusion, does it?
Yeah, it's a good question, and it comes up a lot. And what I would say is that, if I were to ask you, would you rather send this molecule that's so important to get right, would you rather send it straight to your brain, or would you rather go by your gut first and create a bunch of visceral noise, kind of malaise, that kind of fluey feeling that you get when psilocybin's coming on, that caused Compass to have a 23% nausea side effect in the room? And you really can't treat that very well. I mean, honestly, ondansetron doesn't work for psilocybin-associated nausea. So it's really probably much more about just roiling the gut from activating those receptors directly, as opposed to like chemoreceptor zone or something like that. So that's just one aspect of it. I think attuning to a patient in real time, given the opportunity cost, the importance of getting it right as a doctor, it's a lot of value. It's very difficult to do that with oral dosing. It comes on so slow.
All right. Thank you. I think that concludes day 2. Thank you all. And would you like to make some announcements?
Yeah, no, I just want to remind you about pre-dinner drinks, 6:45. You've got an hour and 3/4. Is that right?
Right?
Yeah. Be there.
Thank you.
Yeah.